Okay. Good evening, all of you, and a warm good evening to all the students. This is a remarkable rapid revision sessions that is being conducted with Dr. Tutorials in collaboration with ISM EduTech. And I hope this sessions that are being lined up for you will help you for your final boost in your revision. So take active, enthusiastic involvement in these sessions. We have kept these sessions crisp and relevant to your exams. We'll be discussing the relevant important theory also. I'll start with some GI theory so that we cover a lot of GI radiology first, and then we'll also do some important emergencies that you come across in radiology, and in the end we'll solve a decent number of questions together. So that would be the more crucial part. We'll be interacting with a lot of MCQ discussion also, right? So the duration of the class, I'll keep it crisp, but I have to cover most important subjects around 2.5 hours to 3 hours. I hope that is okay. So I see a lot of people joined in. Good evening, everybody. So how's your preparation in the final stage now? A lot of revision sessions are being planned, guys. Okay, so you can log in and cover a lot of subjects. The schedule is also shared, right? So this will be sessions that will be available on YouTube. So you can go through them one by one, right? Different subjects will be interacting with different eminent faculties, and this final revision sessions will be crisp and high yield for your exams, right? And don't worry about the exams, right? We have enough time to revise, right? Good 40 days from now, lot of change will happen, right? So a good revision from now, a lot of difference will happen. So believe in the process and keep doing your 100%, right? So let's get started. I'll keep interacting in between. So keep it very, very interactive. I'm looking at your chat, right? So Zahid, Shaukat, Arun, right? Aditi, everybody, Ankit, right? Saloni, everybody. I'm constantly interacting with all of you, Samir, Samira, Divya, and all. So keep interacting, and I'll keep updating as we go through. So let's get started with the first image here. So what do you think is this image showing you? First, can you tell me what is this image? Look at this chest radiograph of an infant, and what do you think is this chest radiograph showing you? So this chest radiograph is showing these bubble loops from the abdomen herniating into the left hemithorax. You can see a lot of bubble loops herniating into the left hemithorax and displacing the heart to the other side. So this is what is called as congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Can you tell me what is the type here? What is the type this is? What is this type? This is Bogdalex. How do you know this is Bogdalex? This is a left posterolateral defect. Posterolateral defect. So because it is on the left hemithorax, this is Bogdalex. If you had bubble loops on the right anteromedial side, this would be called as Morgagnis. Morgagnis is right anteromedial, whereas your Bogdalex is your left posterolateral. So because if you see the defect here in the left hemithorax, this better answer here should be what? Bogdalex hernia. So this is Bogdalex hernia, a congenital diaphragmatic hernia. Now, what about this? GI will be easy. First, we'll finish GI and then we'll go to the more important ones. What do you think is this image showing you? Simple one. This is a barium swallow image showing a posterior midline outpouching in the neck. This is Zenker's diverticulum, right? So whatever are easy, I'll just run through fastly. We have a lot to cover. So we'll see that this discussion gives you a lot of information in the limited period that we have. So this is Zenker's diverticulum, posterior midline diverticulum. Very good. Okay, this is easy. All of you will answer this. This is corkscrew esophagus. Where do you see this corkscrew esophagus? This is diffuse esophageal spasm. Corkscrew esophagus on a barium swallow. This is diffuse esophageal spasm. What about this image, guys? What do you think is this image showing you on a barium swallow? Anybody? This fourth image? Can you try this? A barium swallow image showing serpiginous filling defects, right? Worm-like filling defects. Can you see all of these filling defects that you are seeing on a barium swallow? This is a barium swallow image. I'm telling you, right? This is barium swallow image, and this is showing serpiginous filling defect. People are saying cancer esophagus. I don't know why you are saying cancer esophagus, right? Not cancer esophagus. This serpiginous filling defect is esophageal varices. Esophageal varices. So the vessels the irregular vessels that you have in the esophagus, they appear as filling defects. Curvilinear, serpiginous filling defects that you have, these things, these are your esophageal varices. Cancer kaisa hoga? How would cancer be? Achalasia, you all know. Achalasia will be what? Bird beak, right? Narrowing. The bird beak appearance, that is achalasia. Bird beak, or also this is called as rat tail appearance also. Both of them is achalasia. Achalasia. Both bird beak and rat tail is achalasia. If you have a rat tailing with irregular shouldering, इस तरह से shoulders आते हैं, right? Shoulder, you know, shoulder, right? So if you see such irregular shouldering, so if you see rat tailing with irregular shouldering on the barium study, this should be CA esophagus. CA esophagus. तो एक बार फिर से देखते हैं. So look at here, serpiginous, irregular, worm-like filling defects on a barium swallow, that is esophageal varices. A bird beak appearance, also called as rat tail appearance, is feature of achalasia cardia. A rat tailing, if you see with irregular shouldering, irregularities and shouldering are seen, that is CA esophagus. Okay, remember these things. Please understand how the CA esophagus differs from achalasia and from the esophageal varices. Let's come to the next one. Here, I have kept some important signs of an important condition. This is idiopathic hypertrophic pyloric stenosis, IHPS. On the radiograph, what is this single bubble that you are seeing? So this is single bubble on the chest radiograph. This is barium meal. When you see the stomach, that is a barium meal. On a barium meal, what are the signs that you have in idiopathic hypertrophic pyloric stenosis? What is this signs called? This is mushroom sign. The first part of duodenum is altered. That is called mushroom sign. You can see it here better. This is mushroom sign. And can you see a narrowing of the pylorus? So this narrowing of the pylorus, this is called as a string sign. Mushroom sign and string sign. Right? Mushroom sign and string sign on a barium meal. This is also suggestive of idiopathic hypertrophic pyloric stenosis. And what is this sign that is seen in idiopathic hypertrophic pyloric stenosis? What is the gastric hyperperistalsis? Gastric hyperperistalsis called. Gastric hyperperistalsis that you see in idiopathic hypertrophic pyloric stenosis. Anybody? What do you call that? This is called as caterpillar sign. Caterpillar sign. So all of these are important signs of idiopathic hypertrophic pyloric stenosis or congenital hypertrophic pyloric stenosis. So the single bubble appearance, the mushroom sign and the string sign, you also have a caterpillar sign. Because of gastric hyperperistalsis, what do you think will happen? If you have gastric hyperperistalsis, what do you think will happen? Will you have lot of gastric residue or less gastric residue in a patient? In a patient with idiopathic hypertrophic pyloric stenosis, what do you think will happen? Will you have more gastric residue or less gastric residue? More gastric residue or less gastric residue? Very good, Saloni. So you will have, these will be less gastric residue, less gastric residue. Because of repeated vomitings, right? So these children will have lot of non-bilious vomiting, right? So because of the non-bilious vomiting, they have less gastric residue. The child is very dehydrated, hungry child that you have. And what is the metabolic defect that you have? What is a metabolic defect? What is the metabolic abnormality you have? Metabolic abnormality you have is hypokalemic, hypochloremic, metabolic acidosis or alkalosis? Metabolic alkalosis. Very good. Alkalosis with paradoxical aciduria. With paradoxical aciduria. Right? You study all of this, olive-like mass in the epigastrium, right? Surgery mein aap log karte ho. And what is the investigation of choice? What is the investigation of choice, by the way, for idiopathic hypertrophic pyloric stenosis? What is the investigation of choice? Ultrasound. And what are the signs that you see on ultrasound? One is called as a cervix sign, right? The thick pylorus is called cervix sign, and the other one you have a target sign, cervix sign and a target sign. These are seen on ultrasound. The investigation of choice is ultrasound. So these are important points that you should know about idiopathic hypertrophic pyloric stenosis. Remember, pyloric stenosis में stomach में content कम है, right? There is less gastric residue. There is less gastric because of repeated vomiting, because of gastric hyperperistalsis that the patient has. And what type of vomiting? Non-bilious vomiting, right? So non-bilious vomiting. Okay, let's look at another, some other barium meal images. Here on a barium meal, I am seeing this meniscus-like filling defect, right? So meniscus, like ये दिख रहा है ना? This is like meniscus-like filling defect, moon-like filling defect that you are seeing. This is called as Karman meniscus sign. Karman meniscus sign. Can anybody tell me where do you see this Karman meniscus sign? Where do you see? Very good. This is malignant gastric ulcer. Malignant gastric ulcer. And where do you see this mucosal line close to the ulcer base, right? When you have the mucosal rugae close to the ulcer base, you see this thin line, the ulcer collar. Where do you see this ulcer collar or Hampton's line? You also call this as Hampton's line. This is feature of benign gastric ulcer. Benign gastric ulcer. So to remember, malignant gastric ulcer will have the meniscus sign. M for M, yaad rakhna. M for M. Malignant gastric ulcer will have meniscus sign, whereas benign gastric ulcer will have the ulcer collar or the Hampton's line, right? So basically what happens is, imagine this is the ulcer in the stomach. In benign gastric ulcer, the rugae reach till the ulcer base. You will see the rugae close to the ulcer base in benign gastric ulcer. So when you see the barium study, the mucosal rugae will be coming close to the ulcer base, giving the ulcer collar or the Hampton's line. So these are features of benign. So mucosal rugae reaching the ulcer base is seen of benign gastric ulcer, right? Next thing, let us look at some abdominal x-rays. More abdominal x-rays. The first one here. This is single bubble. You all know single bubble. This is idiopathic hypertrophic pulmonary. Double bubble kahan rahega? This is the stomach, this is the duodenum. Where do you see this double bubble? The first part of duodenum. This is seen in duodenal atresia. Duodenal atresia. Any other cases you can tell me? Any other causes you can tell me other than duodenal atresia also? Any other causes? Even in annular pancreas. Very good. Annular pancreas mein. And anywhere else you can see? Anywhere else you can see? Very good, Bhavya. Anywhere else you can see this? You can also see this with lad bands, right? So lad bands. So when you have lad bands also, the adhesions that you have, they can also produce this double bubble appearance. So remember lad mein sare, right? Lad bands, annular pancreas, duodenal atresia, they will produce double bubble appearance. So double bubble appearance, right? Seen with lad bands, annular pancreas and duodenal atresia. And look here, you are seeing a part of the stomach, part of the duodenum and part of the jejunum here. So you are seeing these three bubbles here. So this is triple bubble. Where do you see triple bubble appearance? Triple bubble is seen in jejunal atresia. Jejunal atresia. Jejunal atresia will have triple bubble. And multiple air fluid levels. Multiple air fluid levels. This is feature of ileal atresia, right? So this is ileal atresia. So just be careful how many bubbles you are able to see on the day of exam. Single bubble, double bubble, triple bubble or multiple air fluid levels, and decide whether it is idiopathic hypertrophic pulmonary stenosis or duodenal atresia, jejunal atresia or a ileal atresia, right? Chalo, let's go forward. Then, okay, coming to another important concept, I want you to understand is between idiopathic, the inflammatory bowel diseases, like inflammatory bowel diseases. This is an important topic that you need to remember in radiology. You must have studied this in your surgery as well as your pathology and many other places. This can be Crohn's disease or ulcerative colitis, right? Ulcerative colitis. I'll only concentrate on the radiology parts. Just concentrate carefully. Crohn's disease and ulcerative colitis, the basic difference that you should all remember, right, is Crohn's disease is transmural. Transmural. This is transmural. That is full thickness. Full thickness is involved. Transmural. Ulcerative colitis is very superficial. So imagine this is the colon and this is the inflammation that is happening. This is full thickness, right, like this. And this is only superficial, only involving the mucosa and the submucosa. So very superficial involvement is seen in ulcerative colitis. A transmural involvement is seen in case of Crohn's disease. Now, because this is transmural involvement with skip lesions, right, and there are some areas which are normal and some areas which are inflamed. There are skip lesions here. Now, because of the transmural inflammation, आपको क्या होगा? Fissures, fistulas, bowel perforation, all of these will be common because this is transmural involvement. So where do you see fissures commonly, fistulas commonly? These are features of Crohn's disease. Whereas in ulcerative colitis, only the mucosa and submucosa are involved. So you'll have mucosal granularity. The earliest finding that you see is the mucosal granularity. right? That is seen in what? Ulcerative colitis. यहाँ पे क्या होगा? Risk of bubble perforation is more, bubble perforation, because transmural involvement. Because of the transmural involvement, all of this is happening. Fissures, fistulas, bubble perforation. This bubble perforation, right, will make the omental fat to come and lie closer. The omental fat will be coming and lying closer to the bubble wall. This is called as creeping fat sign. Creeping fat sign. Creeping fat sign. And because of that, the vasa recta that you have become very visible, because you actually fats are hidden rehte hain. The fat would be hiding these areas, but once you have the creeping fat, all the vasa recta become much more visible. That is called as your comb sign. Comb sign. Comb sign. So all of this is because of the transmural inflammation, fissures, fistulas, bowel perforations, creeping fat sign, right, comb sign. All of these are features of the Crohn's disease. In ulcerative colitis, because the inflammation is only superficial, right, so there is a superficial involvement, the lesions will only occur in the mucosa and submucosa, do not go into the muscle layer and all. So that is the reason these are called as buttonhole ulcers, right? So very superficial buttonhole ulcers will be seen, right, in case of ulcerative colitis. Next, what happens in Crohn's disease is once you have the comb sign and creeping fat sign, the fat that is coming, if I take a cut section, so there's a transmural inflammation. If I take a cut section, you will see fat around it, right? So this is called as target sign. So target sign is also a feature of Crohn's disease. And because there is transmural involvement will heal with fibrosis. And these are skip lesions, so these are normal, this is normal, and in between this is fibrosis or stricture that is occurring. This is called as string sign of Cantor, string sign of Cantor. So where do you see string sign of Cantor? The narrowing of the barium that you have. This is also a feature of what? Crohn's disease, Crohn's disease. So all of these are important findings that you should remember. What you're having in Crohn's disease, fissures, fistulas. These fissures, fistulas, they form the rose thorning. इस तरह से fissures, fistulas जब हो जाएंगे, that is called rose thorning. Rose thorning is also a feature of, all of these are features of Crohn's disease, Crohn's disease. Whereas ulcerative colitis, you are having mucosal granularity, the mucosal involvement is there, you are having buttonhole ulcers. And because it is colon that is involved, right, the colon, the rectum and the colon that is involved, there is loss of hostrations in the large colon, right, loss of hostrations. So you see a colon which does not have the normal hostrations. You have hostrations like this in the periphery, you don't see these hostrations. So this appearance is called as lead pipe appearance. So where do you see lead pipe appearance? This is feature of ulcerative colitis. Lead pipe appearance is ulcerative colitis. So let us look at those images. Let us just understand. So remember, everything is about transmural and superficial involvement. Buttonhole ulcers, right? Your presence of mucosal granularity. There is also this lead pipe appearance. All of these are features of ulcerative colitis. Whereas Crohn's disease is transmural. Fissures, fistulas, strictures, fibrosis, bowel shortening, gut shortening, bowel perforation, creeping fat sign, comb sign, target sign. All of these are features of what? Crohn's disease. String sign of Cantor is also a feature of Crohn's disease. I hope you remember this thing. So if you look at the images here, this is what is string sign of Cantor. This is string sign of Cantor. Where do you see this narrowing stricture that is there? This is Crohn's disease. And can you see this vasa recta that are prominent? Can you see the blood vessels that are prominent here? I hope you can see these things here. These vasa recta. What do you call this sign as? What do you call this sign? This sign is called as comb sign, right? So this is called as comb sign, right? So this is comb sign. And how do you see here? How are you finding it here? This is, what is the appearance? Do you see any hostrations in the colon? Do you see any hostrations in the colon? Do you see any hostration in the colon? No. So this is lead pipe appearance. And where do you see this lead pipe appearance? Lead pipe appearance. This is feature of ulcerative colitis. This is ulcerative colitis. Loss of hostrations, right? This is lead pipe appearance, ulcerative colitis. I hope this topic of inflammatory bowel disease, especially with the radiology part, is clear. Where do you see lead pipe appearance? Where do you see creeping fat sign? Okay, target sign. I hope that is fine, right? Chalo, let's move forward. Now look at this abdominal X-ray, guys. Look at this abdominal X-ray. Can you see at the splenic flexure of colon? What is the importance of splenic flexure? What is the importance of splenic flexure of colon? आप लोग को पता है स्प्लेनिक फ्लेक्चर पे क्या चीज इंपॉर्टेंट है एनाटॉमी में? स्प्लेनिक फ्लेक्चर ऑफ कोलॉन. The splenic flexure of colon, this is watershed area, poor blood supply, right? Watershed area of colon. It is supplied by the anastomotic branches of superior mesenteric and inferior mesenteric. There is no direct blood supply. So, the watershed area. So, whenever you have ischemia, there will be first involvement of the splenic flexure of colon. So, you will see mucosal edema that gives this thickening of the mucosa. This is called thumbprint. So, this is called as thumbprint sign. This is thumbprint. Where do you see this thumbprint sign? Which colitis? Ischemic colitis. When you have poor blood supply in that area, ischemic colitis. It can also be seen in other colitis, right? Inflammatory and non-inflammatory colitis, but basically studied classically with ischemic colitis. Thumbprint sign is feature of colitis, especially ischemic colitis. The mucosal edema will show as thickenings at the splenic flexure of colon. So look at the splenic flexure. अगर thumbprint sign पूछा गया और ischemic colitis पूछा गया exam में, look at the radiograph, especially at the splenic flexure of colon. Is it okay? Chalo, let's come to the next one now. Now, a very important topic, guys. This is important for your exam. We are going to talk here about the radiological findings of ileocecal tuberculosis, ileocecal TB. You will study this even in your surgery, so listen carefully on this topic. Ileocecal TB, first understand what is normal. In normally, imagine this is the terminal ileum, this is the cecum, and this is the appendix that you have. This is the ileum, this is the cecum, and this is the appendix, right? This ileocecal angle, this is usually 90 degrees, okay? It's a right angle. But in case of tuberculosis, what happens? There are a lot of mesenteric lymphadenopathy and fibrosis hona shuru hota hai. What will happen because of this? The cecum is pulled up. So the cecum will get pulled up. So you will have a pulled up cecum. This cecum will be pulled up. You will be pulled up cecum. And because of the pulled up cecum, the ileocecal angle, this is the appendix and this is the ileocecal angle. There is widening of ileocecal angle. There is widening of ileocecal angle or obtuse ileocecal angle. There is thickening of terminal ileum and thickening of the ileocecal valves. There is thickening of the ileocecal valves. This thickening of ileocecal valves, this is called as Fleshner sign. Fleshner sign. So this one, you are seeing the thickening of the ileocecal valves. This is Fleshner sign. Thickening of ileocecal valves. So what are the findings that you have in ileocecal TB? You will have pulled up cecum. Yaad karna important for your exam. Pulled up cecum, right? You are having widening or obtuse ileocecal angle, right? From a right angle, it becomes obtuse ileocecal angle. You will have thickening of ileocecal valves. And the whole appearance, because of this, the whole appearance of the colon. So you can see the pulled up cecum, right? The cecum is pulled up. You can see a narrow terminal ileum. All of this, and there is a widening of obtuse ileocecal angle. All of this will produce what is called gooseneck deformity. Gooseneck deformity. All of these are findings that you see in ileocecal tuberculosis. And if I ask you what type of ulcers do you see in ileocecal TB? In TB in the gut, what type of ulcers do you see? Do you see longitudinal ulcers or transverse ulcers? Transverse ulcers होते हैं TB में या longitudinal ulcers होते हैं? Can you tell me, do you see longitudinal ulcers or transverse ulcers? Very good. TB will have transverse. Remember T for like this. TB has transverse ulcers. TB has transverse ulcers. Typhoid, you remember like this. Typhoid. Typhoid has longitudinal ulcers. TB has transverse ulcers, right? And one more important thing that happens here in tuberculosis, one important thing that remember in TB is when you give contrast studies, when you do barium studies, the barium will come in the normal areas, but in the inflamed areas, it will be washed off fastly. There is rapid emptying of barium. So this rapid emptying of barium that you have, what do you call that? Rapid emptying of barium. So the barium will not stay in the diseased area. Rapid emptying of barium from diseased segments. What do you call this? Anybody? What do you call this? This is called as Sterling sign. Sterling sign. Right? So remember, all of these are important signs of ileocecal TB. Ileocecal TB exam के लिए important है, right? You should not miss any of these signs. Pulled up cecum, widening of ileocecal angle, obtuse ileocecal angle, Fleshner sign, right? You have a gooseneck deformity. Also, remember the Sterling sign, the rapid emptying of barium from the disease segment. These are all important signs that you see with ileocecal TB. Simple, just if you think over, you'll get the whole answers, right? The Fleshner sign is also called as inverted umbrella sign. So this Fleshner sign, this is also called as inverted umbrella or inverted umbrella sign, right? Same thing, Fleshner sign, the thickening of ileocecal valves is also called as the inverted umbrella sign. Now let's move forward. Now, what do you think is this image showing you? What is this image? Can you tell me? Is it barium meal follow through? Is it MR enteroclysis, CT enteroclysis? What do you think is this? ये image क्या है? Can you name what this image is? How are the bones first of all? The bones are what? White. So the bones are white. This must be CT. How are the bubble loops? Are the bubble loops distended or not? You can see distension of the bubble loops. Can you see the rugae? Can you see the mucosal rugae? You can see the mucosal rugae. So this is CT enteroclysis. CT enteroclysis. So in CT enteroclysis, you have distension of the bubble with, you can evaluate the mucosal rugae much clearly. You use a NJ tube, nasojejunal tube. You go into the jejunum and then put a double contrast. You put, methyl cellulose, you put barium, you distend the bubble loops and then take the CT scan. So this is a double contrast study that is done where you have distension of the bubble loops to see the mucosal rugae better. So you use NJ tube. In this, we use nasojejunal tube. Right? Not a nasogastric tube. We don't just put it in the stomach. We go into the jejunum and then put the contrast. This is called NJ tube. Right? So CT enteroclysis to look at the mucosa better. Now, we all know the bones appear dark on MRI. So you can see the hip bones, the pelvic bones, they're all dark. And you can see T1, the fluid will be dark, and on T2, the fluid will be white. So this is T1 weighted image, this is T2 weighted image, and in both of them, you can see the bubble is distended with mucosa, right? So this is MR enteroclysis. This is MR enteroclysis. So CT enteroclysis and MR enteroclysis. Look at the bubble here. There is thickening of the bubble, and you can see contrast going as small areas between. What do you call this sign? This is called as accordion sign. Accordion sign, right? So this is accordion sign, feature of pseudomembranous colitis. So the infection, Clostridium difficile infection, right? So Clostridium difficile infection, when it causes this colitis, it causes thickening of the bubble and the mucosal edema and the thickening of the bubble. The contrast will go as thin lines between them. So this is called as accordion sign, feature of pseudomembranous colitis. And where do you see this whirlpool sign? The twisting of bubble loops across the superior mesenteric vessels, right? So the whirlpool sign, this is feature of midgut volvulus. Important, remember these signs that will be asked in the exam. Whirlpool sign, midgut volvulus or non-rotation. Next, where do you see this coffee bean sign? Coffee bean sign. Coffee bean sign. What do you see this? Where do you see this coffee bean sign? Coffee bean sign is feature of sigmoid volvulus, right? Sigmoid volvulus. And in this, you can see the cleft directed towards left iliac fossa, right? The cleft of the coffee bean will be directed towards left iliac fossa, right? And we'll talk about sigmoid volvulus in more detail. But can you also tell me what is this sign that you see in sigmoid volvulus? ये भी पूछ सकते हैं. What is this barium enema study? This is bird beak appearance. So be careful, bird beak appearance on barium swallow पूछा गया या barium enema पूछा गया. If they say bird beak appearance on barium enema or bird of prey appearance, bird beak appearance or bird of prey appearance, please think of sigmoid volvulus, right? So when you have a sigmoid volvulus and you do an enema, there's tapering of the column of barium there, called as bird of prey appearance or bird beak appearance on barium enema. So be careful, swallow bola gaya ya enema bola gaya. Enema, this is sigmoid volvulus. Swallow, that would be achalasia cardia. And what is this image showing you? Can you tell me? Can you identify what is this image telling you? Can you tell me what is this image? Let me zoom it for you. Can you tell me what is this barium study showing you or a barium enema image showing you? Can you see small outpoachings like this, especially on the mesenteric side? Especially on the mesenteric side, जहाँ पे mesentery होती है, वहाँ पे आ रहा है यहाँ पे. So these small outpoachings that you see on the mesenteric side, this is diverticulosis. Diverticulosis. Diverticulosis, they are mainly seen on barium enema. The investigation of choice is barium enema. You see this mucosal outpoachings that you are seeing. And these outpoachings that you are having, this occurs on mainly on the mesenteric side. Mesenteric side. Diverticulosis. होता क्या है जो bubble है, this is the bubble and these are the vasa recta that you have, the vasa recta. So whenever there is, the vasa recta entering into the bubble, these are weak areas. So whenever the outpoachings happen, they happen at these vasa recta, producing this, sawtooth appearance that you see on a barium enema. So this is called sawtooth appearance, right? Sawtooth appearance on barium enema. This is feature of diverticulosis. Diverticulosis. Where do you see Meckel's diverticulum? Meckel's diverticulum कहाँ पे होता है? Mesenteric side होता है या anti-mesenteric side? Meckel's diverticulum कहाँ पे होता है? Meckel's diverticulum, where do you see this? Is it on the mesenteric side or anti-mesenteric side? Mesenteric side or anti-mesenteric side? Can you tell me one word? Very good. This is on anti-mesenteric side. Very nice. This is on the anti-mesenteric side. So Meckel's diverticulum is on the anti-mesenteric side, whereas diverticulosis occurs on the mesenteric side, right? Now, ये तो आप लोग सब आंसर करेंगे. I am sure you will answer this easily. Can you tell me what is this? This is, what is this? Apple core appearance. Will not waste more time. Apple core appearance. This is feature of CA colon, right? So CA colon, apple core appearance. Can you see this shouldering? दिख रहा है ना? Cancers में ये shouldering दिखती है. तो याद रखना है कि बेरियम esophageal cancers में भी अगर आप देख रहे हो, right? I told you to look at the shouldering. So this is what I mean by shouldering, especially cancers में. You try to appreciate that. That is what the shouldering is. Okay, so shouldering. This is colon cancer. Okay. When there is failure of migration of neural crest cells, जो neural crest cells है वो migrate करने से failure होते हैं, especially they don't reach towards the rectum and the sigmoid colon. This is Hirschsprung's disease. Hirschsprung's disease. Right? This is failure of migration of the neural crest cells, and you have a prominent colon proximal to that, and this dilated colon that you have, this is megacolon, right? So megacolon. Okay. So Hirschsprung disease, you'll have this. And which is the diseased part? Is the constricted part diseased or dilated part? Which is the diseased part? Constricted part or dilated part? कौन सा diseased है? Which is the diseased part? Can you tell me constricted part or diseased part? Which one? So this is the diseased part, right? So always rectum is involved. This is the diseased part, right? Rectum is always involved and it is constricted. Right? So this is the constricted part. So if the rectum is always involved, so what do you think will happen to the rectosigmoid junction? The rectosigmoid junction ratio. Rectosigmoid ratio क्या होगा? Will it be more than 1 or less than 1? Rectum is constricted, then the sigmoid colon. If I take the diameter of the rectum and the diameter of sigmoid colon, do you think it will be more than 1 or less than 1? What do you think? What do you think? Rectum numerator क्या है? Numerator कम है and denominator sigmoid colon, it is like this. If you see the sigmoid colon and the rectum, कभी कभार ऐसे images भी आते हैं. This is sigmoid colon and this is rectum. So the rectum diameter is less, sigmoid colon diameter is more. So the rectosigmoid ratio less than 1. This is also Hirschsprung's disease. Hirschsprung's disease, right? So less than 1. So this is also Hirschsprung's disease. Please remember, normally the rectum should be more caliber. Normally, this is how Hirschsprung disease is. Normally क्या होगा? Sigmoid colon and the rectum. If you see normally, the rectum is big. This is rectum, this is sigmoid colon. Normally the rectosigmoid ratio is more than 1. This is normal. But if it is less than 1, that is Hirschsprung's disease. So remember the failure of migration of neural crest cells. Right? This is always involving the rectum. The rectum is a constricted part. So the rectosigmoid ratio should be less than 1. This is Hirschsprung's disease. Can you see here? This image can be given and they'll ask you what is this image showing you. This is also Hirschsprung's disease. You can see the rectosigmoid ratio is less than 1. Right? So this is also Hirschsprung's disease. The rectosigmoid ratio less than 1. Right? Are we clear? Next. Okay. The exams are not over. All those people are asking for the sessions and all, right? Everything is planned. Okay, just आप लोग अपने पढ़ाई पे ध्यान दो. It is our responsibility to see that you're all, comfortable, right? So don't worry on that. You've not gone into the exam to start. So believe in the process and everything will be taken care. Okay, this is all planned, right? You will not know that, but just study. Keep doing your work and you should be fine. Okay. Anyways, chalo. What do you see here? What do you see here? What do you see here in the bubble? In the bubble, you are seeing lot of, intramural air. So this on the abdominal radiograph, you are seeing intramural air. What do you mean by intramural air? Air within the wall of the bubble. So this is the bubble and you are seeing air here. You are seeing the air here. You are seeing the air here. So intramural air, you are seeing intramural air. This is called as pneumatosis intestinalis. Pneumatosis intestinalis. In which conditions do you see pneumatosis intestinalis? Pneumatosis intestinalis, from here, it will go into the portal vessels, right? So which vessel will take the bowel loops, will take the blood from the bowel loops? The portal vein. So these air can also come into the portal vein. So intramural air, that is pneumatosis intestinalis and portal vein gas, if it is seen in a premature infant, right? This is necrotizing enterocolitis. And if you see in an elderly smoker, atherosclerotic smoker, this is your superior mesenteric artery thrombosis or a mesenteric ischemia. So this is pneumatosis intestinalis and the portal vein gas. So if you see intramural air within the wall of the bowel, this is called as pneumatosis intestinalis and portal vein gas. If you see it in a premature infant, that is called as necrotizing enterocolitis. And if you see in an elderly smoker with atherosclerosis, think of mesenteric ischemia, the SMA obstructions, okay, SMA thrombosis, like that. That is about the important things that we had. Another very important topic in GI radiology is to understand pneumoperitoneum or hollow viscous perforation. Hollow viscous perforation or pneumoperitoneum, you can see air under the right hemidiaphragm. So if you see air under right hemidiaphragm, this is suggestive of hollow viscous perforation or pneumoperitoneum. And to look at the air under right hemidiaphragm, the best X-ray view is a chest X-ray erect. The best X-ray to look at the domes of diaphragm. Bowel perforation or ileal perforation, duodenal perforation, in a hollow viscous perforation, you need to take a chest X-ray. The best X-ray view to look at hollow viscous perforation is a chest X-ray erect. And what are the other signs that you have in pneumoperitoneum or hollow viscous perforation? ये important signs से पूछे जाते हैं exam में, okay? Because hollow viscous perforation or pneumoperitoneum is an emergency. You need to know all these signs related to hollow viscous perforation or pneumoperitoneum. One is the air under right hemidiaphragm. ये X-ray is very, very classic. All of you should know this. The next thing that you have is cupola sign. Cupola sign, this is C for C, air under central tendon of diaphragm. Dougie's cap sign is air in the Morrison's pouch. And all the ligaments will stand out because air is there in the abdomen. All the ligaments will stand out. The falciform ligament, the lateral umbilical ligament, right? The median umbilical ligament. The median umbilical ligament is the urachus. The lateral umbilical ligaments, they form the inverted V sign. Also, the ligamentum teres will be standing out. So, all the ligaments, because of the abdominal air, all the ligaments will stand out. There will be a football sign, right? With the distended abdomen that you have. Wriggler's sign is air on either side of the bowel wall. Normally, you see air in the lumen. But if you see air on either side of the bowel wall, indicates perforation. Agar perforate hoga, to air will come on either side of the bowel wall. Air on either side of the bowel wall is called as Wriggler's sign. So what are the signs once again? Cupola sign. Cupola sign is air under central tendon. Dougie's cap sign. What is Dougie's cap sign? Air in the Morrison's pouch. Between the liver and the kidney, you see the air here. You see the air here like this. This is called as Dougie's cap sign. You also see falciform ligament sign, inverted V sign, right? The median umbilical ligament sign or urachus sign, all of this. You can see here. This is air under central tendon. What is this? This is cupola. Cupola is air under central tendon. Air under right hemidiaphragm or air under central tendon. And you can see on the CT scan. Remember, the investigation of choice for air anywhere is CT. So on the CT, you can see this is the liver, and anterior to liver, you are seeing the free air. This is your pneumoperitoneum. Here you can see inverted V. I hope you can appreciate these are the inverted V's, the lateral umbilical ligaments. And you can also see the football, right? So the football. And the falciform ligament of the liver will also stand out. So falciform ligament sign, inverted V sign, all the lateral umbilical ligament sign, and football sign. Can you see this is bubble loop, and outside the bubble loop also you are seeing air. So this is air on either side of the bubble wall, air on either side of the bubble wall. This is called as Wriggler's sign, Wriggler's sign. Air on either side of the bubble wall is called as Wriggler's sign. So these are all the different signs that you have, right, with hollow viscous perforation or pneumoperitoneum. Once again, we'll do them. Air under right hemidiaphragm, cupola sign. What do you mean by cupola? C for C, air under central tendon. Then what are the other signs you have? All the ligaments will stand out. Falciform ligament, ligamentum teres, medial umbilical ligament, lateral umbilical ligaments. The lateral umbilical ligaments are also called as inverted V sign. You also see football sign and the Wriggler's sign. What is Wriggler's sign? Air on either side of the bowel wall. What is Dougie's cap sign? Air between the liver and the kidney, the Morrison's pouch, air in the Morrison's pouch. That is called as your Dougie's cap sign. एक और sign होता है called as telltale triangle sign. Telltale triangle sign. You see triangle, imagine this is the abdominal wall. These are the intestinal loops that we have. So you will see air, triangular air pockets that are trapped. There are triangular air pockets that are trapped between the intestine and the bowel wall or between the loops of the intestine. So you see such triangular air pockets. None of the bowel loop is triangular. So if I take an abdominal X-ray and I see a triangular air pocket, this is called telltale triangle sign. If I see triangular air pockets, it tells you that it is not luminal air. It is telling me a story that it is not a luminal air, it is extraluminal air. There is perforation here. There is hollow viscous perforation here. None of the bubble is triangular. If I see triangular air pockets on an abdominal X-ray, I should understand that this is hollow viscous perforation. This is called as telltale triangle sign. It indicates extraluminal air, right? Hollow viscous perforation. By the way, what do you do if you see any of these kind of images, right? Here you can see this is falciform ligament sign. Right? यहाँ पे अच्छे से दिख रहा है falciform ligament sign, and you can also see the football, right? So the football sign. By the way, if you are having a case of hollow viscous perforation or pneumoperitoneum, क्या करोगे आप? Hollow viscous perforation or pneumoperitoneum, what would you do? What is the immediate treatment? What would you do? This would be IV fluids or resuscitation. So that these patients are under shock. So a lot of time they need IV fluids resuscitation. Along with that, you go for emergency laparotomy. Don't just write emergency laparotomy. Look at the options carefully. Agar IV fluids along with emergency laparotomy, that is a better answer. Or resuscitation diya gaya with emergency laparotomy, that is a better answer. Okay, so remember IV fluids also, not just emergency laparotomy. Please remember to give IV fluids and emergency laparotomy. Okay. Okay. Look at this abdominal X-ray, guys. Look at this abdominal X-ray. What do you think? ये क्या है? What do you think is this abdominal X-ray showing you? Bowel loops, where are they present? Are they present in the center or periphery of the abdominal X-ray? Are they in the center or they are peripherally located? Are they central or very good, Divya? These are more centrally located. So these are central loops. And if you see carefully, they are located one above the other, right? So they are above one above the other. So they are above one above the other. That is called step ladder pattern. And all of these central loops, one above the other, the step ladder pattern, all of these are suggestive of small bowel obstruction. These are suggestive of small bowel obstruction. Can I ask you which part of the small bowel? Is it a jejunal obstruction or is it a ileal obstruction? Can you tell me whether it is small bowel or, whether it is jejunal or ileal? When you see central loops, when you see loops one above the other, this is small bowel obstruction. In small bowel obstruction, which one is this? Is it jejunal or ileal obstruction? Is it jejunal or ileal obstruction? Let me zoom it for you. Can you see these circular mucosal folds running through and through the bowel wall? Running through and through. Pura complete, right? They're all complete like this. Through and through the bowel wall. What do you call this? These are plica circularis or valvulae conniventis. Plica circularis or valvulae conniventis. Where do you see such kind of plica circularis or valvulae conniventis? These are features of jejunal obstruction. So this is jejunal obstruction. So the correct answer should be jejunal obstruction. But how do you say this is jejunal obstruction? Because of plica circularis or valvulae conniventis. Right? And what is this appearance on the radiograph called? This is called also the air fluid levels. They are present one above the other. This is step ladder pattern. Step ladder pattern. This is also small bubble obstruction. So remember, small bubble obstruction has this step ladder pattern, string of bead appearance. So this appearance where you have one above the other, this appears like string of beads. String of beads. This is step ladder. One above. I'll show you this here. Okay, one above the other. This is step ladder. Okay, more like this. These are all step ladder. Here's step ladder. And this is string of beads. This like this is the string of bead appearance. So all the S that you have, string of bead appearance. S, right? String of bead appearance. And you also have solid feces sign. All of these are features of small bubble obstruction. SSS. याद रखना है, step ladder pattern, bubble loops one above the other. String of bead appearance, small dilated air fluid levels one above the other, just giving that string of bead appearance. And solid feces. You don't see feces in the small bubble. If feces is formed in the small bubble, that means there is small bubble obstruction. Small bubble obstruction. All of these are features of small bubble obstruction. याद रहेगा? तो look at the radiograph, central loops one above the other, step ladder pattern दिया गया, या फिर you are seeing this string of bead appearance, or you are seeing this valvulae conjunctivis throughout, right, the bubble wall. You are seeing this mucosal folds. All of this is small bubble obstruction. SSS, string of bead appearance, step ladder appearance, solid feces sign. All of them are features of small bubble obstruction. Small bubble obstruction. Look here, peripherally located, right? So these are all peripherally located. Very large diameter, peripheral. Very large caliber is there, right? So this is all how you have large bubble obstruction, large bubble obstruction. And large bubble obstruction, is this a ileus or not? How do you know, is it functional ileus or not? अगर ये functional ileus है, right? Ileus है. How do you know it is ileus or not? If it is functional ileus, the rectal air will be present, right? So along with the distension, you will also see air in the rectum. If it is large bowel obstruction due to some kind of mass or some kind of constriction, you will not see the air in the mechanical obstructions. You will not see air in the rectum. But if you see air in the rectum, that is usually a pseudo obstruction, okay, ileus, okay, functional ileus that you have, right? So that is how we need to remember how to differentiate. So look at large bowel, you don't see the step ladder pattern. You see peripheral loops, very large caliber, and you don't see any step ladder pattern, right? You will see hostrations, right? In a large bowel, you see hostra. Hostra are only in the periphery, right? So these are only peripheral folds that you have. So hostrations are present in large bowel obstruction. That is all simple. We have discussed this. This is sigmoid volvulus, coffee bean sign, sigmoid volvulus, and this is cecal volvulus. And a very important differentiation, how to differentiate sigmoid volvulus and cecal volvulus. देखने में दोनों में coffee bean दिख रहा है. How do we write which is sigmoid volvulus and which is cecal volvulus on the exam? Be careful with this. Let me make a brief description between sigmoid and the cecal volvulus. Sigmoid volvulus and the cecal volvulus. Sigmoid volvulus, both of them will have coffee bean appearance. Sigmoid volvulus, it will be like this, right? So you have it extending from the right upper quadrant till the left iliac fossa. You have this bubble loop distending, and you will see two bubble loops. This is one and this is two. So you have two loops. You have three dense lines here. Okay, Freeman-Dahl sign that you say, three hyperdense lines you are seeing. Okay, like this. 1, 2, and 3. All of them are merging and converging at one side, right? That you have three hyperdense lines. Okay, and you also see no hostrations. No hostra in sigmoid volvulus. So you will have two loops. You have no hostra, and it is extends from left iliac fossa to right upper quadrant. Whereas cecal volvulus, on the other hand, cecum is a very big caliber, right? Of the large, all parts of large bubble, cecum has more caliber, more diameter. So you will see a very large caliber with hostrations. So these hostrations are present because already it's a very big caliber. The hostrations persist in cecal volvulus. So cecal volvulus, hostra are present. In this, you will see only one loop. Only one loop is there. And in this, they give the appearance of an embryo sign. The embryo sign की तरह दिखेगा, right? Looks like an embryo. So embryo sign, one loop of bowel, hostrations being present. So like this, hostrations are present. This is all what is called as cecal volvulus. If you look at the history also, history is also slightly different. Sigmoid volvulus will be a generally elderly patient with neurological problems. Parkinsonism or other neurological problems will be there. And sigmoid volvulus will be associated with large bowel obstruction, right? Before sigmoid, again, you'll have large bowel, right? The descending colon, transverse colon. Cecal volvulus, this will be generally younger patients with either, pregnancy or pelvic surgeries. And these are associated with small bowel obstruction. Obviously, before cecum, you have the ileum and jejunum. So, cecal volvulus will be associated with small bowel obstruction. Sigmoid volvulus will be associated with large bowel obstruction. Usually, elderly patients, neurological symptoms are sigmoid volvulus, whereas young patients with any pelvic surgeries, pregnancies, these are cecal volvulus. Hostrations are present in cecal volvulus, hostra, large caliber of the cecum, so hostra persist. Sigmoid colon, the hostra disappear after the volvulus, right? So this is how you differentiate. Two loops are seen in sigmoid volvulus, one loop is seen in cecal volvulus. I hope this is clear for you. Are we clear with this? So this is about sigmoid volvulus and cecal volvulus. Okay, look here. Here also I can see a coffee bean. What do you think is this? Can you tell me what is this image showing you? What do you think is this image showing you? Here, there is a patient with epigastric pain, there is retching without vomiting, and also inability to pass nasogastric tube. There is epigastric pain, there is inability to pass nasogastric tube. And there is also retching without vomiting. What is all this along with this radiograph telling you? Very nice. All of this is what is gastric volvulus. Gastric volvulus. Okay. So this is how we have gastric volvulus. So just by seeing coffee bean, don't blindly write sigmoid volvulus everywhere. Look at the clinical scenario given. Look at what the clinical question is talking about and choose correct, whether gastric volvulus or sigmoid volvulus or cecal volvulus in the exam. Okay. I hope this is, most of you will answer this. What do you think is this? What do you call this? This is very nice. Claw sign or pincer sign. Claw sign or pincer sign. This is feature of intersusception. Intersusception, right? So claw sign or pincer sign. This is intersusception. And one also important sign of intersusception is when you see the column of barium between the two bowel loops, it gives this coiled spring appearance. So coiled spring appearance is also a feature of intersusception, right? Coiled spring appearance. And this coiled spring appearance indicates reduction, indicates reducibility. Right? So it indicates that there is movement. You can reduce this by doing this hydrostatic or air enemas. You can reduce this. This is what the coiled spring sign tells you, that it is indication of reducibility of this intersusception. It's a good finding that you have. So this is claw and this is the coiled spring. Both of them are signs of intersusception. And on ultrasound, intersusception on ultrasound. So when you have one bowel loop gone into the other, when you have one bowel loop gone into the other, and you take an ultrasound image, you will see a donut appearance or a target appearance also, or a pseudo kidney appearance. So donut appearance, pseudo kidney appearance. So on a short axis view, on ultrasound probe, on a short axis view, you will get the donut appearance, pseudo kidney appearance, or a target sign. All of these are signs of intersusception. Okay, so be careful with these things. So here, like this, CT scan image will be given, and you can see this is the part of the bowel which is entering into another bowel. So this is how you have the intersusception, right? So this is how the intersusception would be. So you will have one part of the bowel, the intersusceptum inside, and the intersuscipiens, which is receiving it. So the intersuscipiens and the intersusceptum. This is how you have the intersusception on CT scan. Okay. Now, I tried to cover the GI part. I hope this helps you understand your surgery and understand your radiology of GI system nicely. Let's come to some important emergencies. GI is okay. All of you just let me know if you're okay with the GI tract. If you're comfortable with the GI tract, can we go to the important emergencies that you come across in radiology? Are you done with the GI tract? Just tell me quickly yes. Okay. Fine. Aditi, Rohit. Next, Dr. Samira, Divya, Akib. So let's look into this next question here. Let's look into this next question. Here, there is a 2-year-old child with sudden onset of respiratory distress. Very, very important topic. All of you should know this. A 2-year-old child with sudden onset of respiratory distress, one inspiratory and expiratory X-rays are given. Right? What is coming to you? Very good, Tanvir. This is foreign body. This is foreign body. Foreign body. Right? This is foreign. Where is the foreign body? Where is the foreign body? Inspiration, expiration, both of them you're seeing. Right? A child with sudden onset of respiratory distress is given. Where is the foreign body? Right lung or left lung? Where do you think is the foreign body? Right lung or left lung? Please remember what you are seeing here. These are your ECG leads. These are not foreign bodies. These are ECG leads. These are not foreign bodies. Let us look at the right lung in inspiration and right lung in expiration. Inspiration, the lung will be big. Expiration, the lung will be small. Let us look at the left lung. The left lung in inspiration and the left lung in expiration. The left lung is showing air trapping in the expiratory. Normally, the lung should inhale and exhale. Inhale and exhale. That is normal. But if air is coming in and not going out, there is air trapping. There is air trapping in expiratory phlegm. Air trapping in expiratory phlegm. Air trapping in expiratory phlegm tells you this is a foreign body. Foreign body. And this is in the left lung here. Left lung. So please remember, whenever we have a foreign body, if there is complete obstruction of the foreign body, the entire lung collapses. So either you have a opaque hemithorax, or imagine there is a foreign body giving a ball-valve mechanism. Air is about to come in but not allowed to go out. There will be air trapping, right? There will be air trapping in the expiratory phlegm, and you will get a lucent hemithorax or a black hemithorax. So either you get a opaque hemithorax or a lucent hemithorax in a child of 2 to 3 year age group. In a child of 2 to 3 year age group, right, with sudden onset of respiratory distress, the child playing left unattended by the mother. A child is left playing unattended by the mother, and that patient develops sudden onset of respiratory distress, right? Please think of foreign body. Either you'll get a opaque hemithorax on the chest X-ray or a lucent hemithorax. You'll see a air trapping in expiratory phlegm producing this lucent hemithorax. Okay, air trapping will because of air trapping in expiratory phlegm. Get this lucent hemithorax. That's the reason we say expiratory phlegm should be done for suspected foreign bodies, right? So expiratory phlegm is taken in suspected foreign bodies, right? I hope this topic is fine. Okay, look at this important emergency again. You are seeing a double rim. Can you see the double rim? Let me zoom it for you. Can you see two rings here? This is one inside and this is the outside. This is the double rim that you're seeing, right? So the double rim that you're seeing. So if you see a double rim, this is button battery. Very good. So this is button battery in the esophagus. This is button battery in esophagus. Right? And button battery is an important emergency. It's very alkaline. It's very, very alkaline. And it can have risk of esophageal perforation. So whether it is symptomatic or asymptomatic, it should be removed. Right? So whether it is symptomatic or asymptomatic, if you see button battery in the esophagus, it should be removed. So by looking at the double rim, you know whether it is a button battery or a coin. If you don't see the double rim, it is a coin. If you see a double rim, that is a button battery. A button battery has risk of esophageal perforation because of its alkaline content. So in the esophagus, it is an emergency. It should be removed immediately by esophagoscopy. A coin in the esophagus will be appearing in a coronal view on the frontal radiograph and will appear like a slit posterior to the tracheal stripe. So this black area is the tracheal stripe. So on the lateral view, it will be posterior to the tracheal stripe. This is how you have the coin in the esophagus. A coin in the trachea on the frontal radiograph will be in a slit-like fashion, and on the lateral radiograph, you will see it completely in the trachea. So that is how you have coin in the trachea. So the only thing to remember is, imagine this is the larynx, and this is the trachea. So between them, we have the vocal cords, right? So in between the larynx, we have the vocal cords. So the coin will have to enter between these vocal cords to enter into the trachea. So it will appear like slit like on a frontal radiograph. It cannot appear in a coronal plane. It will appear in a sagittal plane on a frontal radiograph because it has to pass between the vocal cords. So if you see it in a sagittal plane on the frontal radiograph and on the lateral radiograph, you can see it completely in the tracheal lucency. This is coin in the trachea. Just remember this much about vocal cords. You will understand how it will be appearing in the esophagus and how it will appear in the trachea. Simple to understand. Okay, just if you remember, larynx has vocal cords, right? Okay. Now, before we go into further, let us see if you can answer few of the MCQs. Okay, so let us do some MCQs and see if you can answer them properly. So I'll mix and match the MCQs and this thing. Let me see how much you can answer. Let us see the MCQs now. Okay, try to answer this one, guys. Today questions kar lete hain. I'll do some questions and then I'll come back to the topic now. Let us do this question. A 52-year-old woman with exertional dyspnea, recurrent transit ischemic attacks, lightheadedness with sudden changes in position, and a 7 kg weight loss over the past 6 months undergoes cardiac CT. The given CT scan image is suggestive of what is this lesion that you have? Very good. Now, this is mostly a radiological anatomy question. You can answer this by just radiological anatomy. The most anterior chamber is right ventricle. The most posterior chamber is left atrium. The most anterior chamber of the heart is right ventricle. The most posterior chamber is left atrium. You can see the pulmonary veins also opening into the left atrium. So this is a left atrial myxoma. Left atrial myxoma. Let us label the chambers. This is right atrium. This is the right ventricle. And this is the left ventricle, right? So this is the left ventricle. Just a radiological anatomy question. You need to just identify this mass that is present in the left atrium, left atrial myxoma. Try to answer this thing. Let us do the second question. Questions थोड़ा जल्दी कर लो so that you can finish a lot of questions of them. A 55-year-old female presents with sudden onset of severe chest pain showing ST elevation on ECG after a stressful emotional burst. Angiography findings are normal, but cardiac imaging demonstrates ballooning of the left ventricle, right, with akinesia of the distal part of the left ventricular wall. Most likely diagnosis is. Very good. So all of you are answering it correctly. This is Takotsubo cardiomyopathy. Remember, apical ballooning of the heart. Apical ballooning of the heart. On echo or cardiac imaging, this is suggestive of octopus spot heart. Octopus spot heart. So the ventricle will balloon out like that. So there is apical ballooning of the heart. That is called as octopus spot heart, feature of Takotsubo cardiomyopathy. This word is important. Apical ballooning is Takotsubo. Let us look at the next question. A child is presented with recurrent UTI. What is the most likely diagnosis here? So you can see a contrast opacified bladder, and you are seeing the contrast opacified bilateral ureters. There is less contrast going into the urethra. So more contrast is coming back into the ureters and less contrast entering into the urethra. This is vesicoureteric reflex. Vesicoureteric reflex. What is the investigation of choice for vesicoureteric reflux? What is the investigation of choice for vesicoureteric reflux? MC, right? Micturition cystourethropy. The grades of VU are also given by micturition cystourethropy or Whiting cystourethropy. Okay, let's do the next one. Ye answer karo. Let me see who will answer this. Let's see this thing. Okay, a delayed intravenous urogram of the patient is shown. What is the likely diagnosis? So you're given an image, a delayed intravenous urogram is given, and what is the likely diagnosis? Staghorn calculus, putty kidney, pelviureteric junction obstruction, or renal cyst. Let me see. Everybody is answering it as putty kidney, B. But B is not the answer. Okay, this is IVP image. IVP image में क्या होना चाहिए? Contrast should come to the kidney, get secreted into the pelviureteric junction, reach the bladder. You can see the right ureter. Compare the right ureter, it is coming, right? And then it is also, the contrast is coming to the bladder. But look at the left kidney and look at the left ureter. I can't see the left ureter. I'm only seeing the pelvis, which is very dilated, the calyces are dilated, and I'm not seeing anything in the ureter. I'm not seeing the ureter. I'm not seeing the ureter. So this thing where the contrast is remaining in the pelvis of the kidney and not entering the ureter, right? This delayed IVP image, this is showing what is called as your pelviureteric junction obstruction. There is no mention of sterile pyuria. There is no calcification here. This is contrast. He already told it is contrast study, right? IVP study, a contrast type. So it is a contrast that is remaining in the left pelviureteric junction, right? So at the left pelvis, the contrast is pulled in. Even in the delayed images, it is still pulled in. That means there must be left PUJ obstruction. So this is a PUJ obstruction. This is a left PUJ obstruction. Okay, so be careful with this expected question, right? So this is left PUJ obstruction. अगर स्टेराइल पायूरिया दिया गया, calcifications, plain abdominal X-ray पे calcification दिख रहा है, then I would understand that would be putty kidney or cement kidney, the tuberculosis of the kidney. But here, this is left PUJ obstruction. Okay. What is this image showing you? A 25-year-old male with infertility underwent HSG. The image is given below. What is the likely diagnosis? Unicornuate, bicornuate, septate, or didylphus? What do you think it is? Very good. There is acute or a narrow intercornual angle. This must be septate uterus. Septate uterus. Next. Look at this next question. A middle-aged male presented with acute onset of pain in the right limb, right? A middle-aged male patient. An investigation is performed. What is the name of the investigation? So you can see some color filling in the blood vessel, and there is some kind of wave pattern given to you. What do you think is this? So this is basically a Doppler ultrasound. When you see such wave pattern, it is more specifically called spectral Doppler. Okay, this is spectral Doppler. And what is the wave pattern here? This is triphasic pattern. A triphasic pattern is normal peripheral arteries. Normal peripheral arteries, they have triphasic pattern. So the correct answer, more specific answer, if you are given this, would be spectral Doppler. But if you don't see spectral Doppler, you can choose Doppler ultrasound. Okay, so this is spectral Doppler, Doppler ultrasound. Very good. Let's look at the next one. What is this? What is this investigation, guys? You can see uptake in the brain, right? If there is uptake in the brain, that means glucose has been used. And how are the bones? The bones are white. The bones are white. So this bones are white. You can see the vertebra, you can see the bones, you can see uptake in the brain. So this is your PET-CT. PET-CT. Remember, maximum radiation exposure out of all diagnostic modalities, maximum radiation exposure is seen with PET-CT. Out of all diagnostic modalities, maximum radiation exposure occurs with PET-CT. If the bones are black, that would have become PET-MRI. Agar bones white hai, to PET-CT. If the bones are black, that would become PET-MRI. Looking at the uptake in the brain, you know glucose was used in the patient. Neurons are always hungry for glucose, right? So 18-FDG will go into the brain. Let us look at this next question. I hope this is very much easy. 11-month-old child, recurrent abdominal pain, a barium enema study is given. This is intersusception. You're seeing the claw sign, right? So you're seeing the claw sign. Simple only. Very nice. Let's go to the next one. Let's go. Try to answer this. Try to answer this. Okay. A 30-year-old patient with presence to casualty after road traffic accident. He has bruises on the chest. Pulse is 120, BP is 90-60, respiratory rate is 40. A chest X-ray is performed and shown below. What is the next most appropriate step in the management? So you're given a road traffic accident, a radiograph is given. What is the next step in the management? What are you seeing here? What are you seeing here? You are seeing absent bronchovascular marking. You are seeing visceral pleural line, visceral pleural line. So when you see absent bronchovascular marking, visceral pleural line, what do? What is the treatment that you do? You go for wide bore needle, large bore needle, followed by ICD, right? Intercostal drain. So you can see a chest tube drainage, right? ICD should be done, right? So the answer should be ICD, right? So the treatment should be ICD, the wide bore needle with ICD. Okay. What is this? A 45-year-old patient complains of recurrent swelling on one side of the neck. She is afraid of eating food. It worsens as it worsens the swelling. So she is having a recurrent swelling in the neck and it worsens after food. imaging is performed, what is the most likely diagnosis? So you can see here at the submandibular area, you are seeing a calcific density that you are having, right? So the calcific area that you are seeing on this radiograph, this is salolithiasis. Okay, so this is usually involving the submandibular glands. Okay, salivary glands are involved. That's the reason the pain is, the swelling is increasing while eating the food. Okay, so salivary gland obstruction, salolithiasis. This is easy. Alcoholic male, severe abdominal pain, rigidity and vomiting, vitals are stable. What is the most effective treatment? So, abdominal pain patient, a chest X-ray is given. Remember, here you are seeing air under right hemidiaphragm. What is the investigation of choice for hollow viscous perforation? Hollow viscous perforation or pneumoperitoneum. This is CT, right? The imaging investigation of choice. Best X-ray view is chest X-ray erect. Chest X-ray erect, right? So, अगर X-ray पूछा गया, chest X-ray erect. But the investigation of choice, the imaging investigation of choice for air anywhere is CT scan. And here, what do? IV fluids and exploratory laparotomy. So that should be done for hollow viscous perforation or pneumoperitoneum. What occurs due to rupture of sacral aneurysm in the brain? This is, what is the type of hemorrhage that occurs due to rupture of sacral aneurysm? This is subarachnoid hemorrhage. What is the most common cause of subarachnoid hemorrhage? Most common cause for subarachnoid hemorrhage? Trauma. What is the most common cause for spontaneous subarachnoid hemorrhage? This is a rupture of perianeurysm or sacral aneurysm. And what is the investigation of choice for acute subarachnoid hemorrhage? That is non-contrast CT. And what is the important clinical symptom that you have? Subarachnoid hemorrhage will produce thunderclap headache, worst headache of his life. Thunderclap headache, right? So all of these are important points about subarachnoid hemorrhage. Let's look at the next one. A patient is having fever, dry cough, breathlessness, night sweats. And this patient on chest X-ray shows bilateral hilar lymphadenopathy. What is the likely diagnosis? Simple, bilateral hilar lymphadenopathy, right? So when you're seeing bilateral hilar, and also you'll have right paratracheal. So 1, 2, 3. This is sarcoidosis. 1, 2, 3 sign, bilateral hilar lymphadenopathy is right paratracheal lymphadenopathy. All of this is what? Sarcoidosis. Remember, Montoux will be negative in sarcoidosis. And ACE levels, angiotensin converting enzyme levels, will be elevated. In sarcoidosis, you may also see miliary mottling. Miliary mottling can be there. तो कभी कभार एक्सरे में, दोनों एक्सरेस में लंग फील्ड्स में स्मॉल मिलेट सीड लाइक ओपेसिटीज देंगे एंड दे विल से द पेशेंट इज हैविंग Montoux negative or ACE levels are elevated. Don't blindly answer miliary TB and come. Right? Also keep sarcoidosis in your differentials, especially when Montoux is negative and you are seeing miliary mottling, ACE levels are elevated. The better answer is sarcoidosis. So 1, 2, 3 sign, bilateral hilar lymphadenopathy, lambda sign and panda sign. Right, lambda and panda sign, these are seen on gallium-67 scan, right? So all of this is sarcoidosis. Let us look at this next question. A 60-year-old male presents with fever, expectoration, difficulty breathing. HRCT of the chest was done and you are seeing this image here. What is this likely condition? Okay, so this is a inverted image. The prone image is there here. This is the vertebra here. Right, so this is the sternum. It's actually imaged prone image here. So you can see here, this is, you are seeing the air bronchograms. So when you see air bronchograms, this is consolidation. You are seeing air bronchogram. This is consolidation, air inside the bronchus. Where are the conditions where you see air bronchograms? Can you tell me which conditions you see air bronchogram? Air bronchogram. What are the conditions where you see air bronchograms? Air bronchograms. Air bronchograms is seen anytime we have alveolar opacities. This can be pus, as in pneumonia or consolidation, right? When you have pus. When we have fluid, as in pulmonary edema. When we have collapse of alveoli, like ARDS or Halley membrane disease. Or when we have a cancer that enters and has aerogenous spread. right, in the alveoli and the airways. That is bronchoalveolar carcinoma, bronchoalveolar carcinoma. All of these are important causes for air bronchogram. So remember these causes of air bronchogram. You're having it in case of pneumonial consolidations. You can see this in cases of pulmonary edema, ARDS or Halley membrane disease where you have alveolar collapse, surfactant deficiency causing alveolar collapse. Can also occur in bronchoalveolar carcinoma. Bronchoalveolar carcinoma resembles pneumonia, right? So we say it resembles pneumonia because of air bronchograms. Right? Bronchoalveolar carcinoma will have air bronchogram. It has aerogenous spread. Aerogenous spread, right? So this is bronchoalveolar carcinoma. Lipidic growth, we say. In your pathology, you will study that lipidic growth, aerogenous spread. As the name says, bronchoalveolar, bronchi and alveoli. All of this is bronchoalveolar carcinoma, right? Next. Let us answer this 15th one. 35-year-old female, 35-year-old male presents with recurrent episodes of abdominal pain, jaundice, fatigue, underwent an MRCP image. What is the likely diagnosis? What do you see here? What do you see here? So you see repeated strictures and dilatations. Repeated strictures and dilatations. These repeated strictures and dilatations, this is what is called as primary sclerosing cholangitis. What is this appearance called, guys? Prune tree appearance. Prune tree appearance on MRCP or ERCP. This is primary sclerosing cholangitis. Okay, so biliary tree involvement, stricture and dilatation of biliary tree. So that is cholangitis. Okay. अगर मैं पूछूंगा प्रून ट्री अपीयरेंस ऑन चेस्ट एक्सरे, एनीबडी? प्रून ट्री अपीयरेंस ऑन चेस्ट एक्सरे, एनीबडी कैन आंसर मी दिस? प्रून ट्री अपीयरेंस ऑन चेस्ट एक्सरे कहां पे दिखेगा? Where do you see prune tree appearance on chest X-ray? On ERCP, MRCP, that is primary sclerosing cholangitis, but chest X-ray pe thick pulmonary arteries that you have, that is pulmonary arterial hypertension, right? Pulmonary arterial hypertension. That is prune tree appearance on chest X-ray, pulmonary arterial hypertension. Okay, answer this one. A 50-year-old patient presented with history of fever, repeated aspirations and coughing in the night. On examination, there is swelling on the left side of the neck, which produces gurgling sound on compression. The following barium swallow image is given. What is the likely diagnosis? So a patient is having repeated aspirations causing pneumonias, fever, coughing in the patient. There is a swelling in the neck, right, producing gurgling sound. Barium swallow image is given. All of this is fine. This is Zenker's diverticulum. Very nice. Okay, very nice. ये क्या है? Image देख के बता दो. A patient presenting with abdominal pain, blood in the stools, palpable mass, right, and a barium study is given. This is coiled spring appearance. This is intersusception, coiled spring appearance. Remember, you will have red current jelly stools, right? Red current jelly stools. Try to answer this question. 18th वाला try करो. 18th वाला try करो. A 10-year-old boy presents with acute onset abdominal pain and episode of vomiting. He also gives history of recent loss of appetite. The abdomen is soft but tender, especially around the periumbilical region. Ultrasound abdomen is done and the following image is obtained. So you can see the image here. And they're asking you, all of the following statements are true regarding this condition except blind ending tubular structure, compressible, absent peristalsis, dilated lumen with wall thickening, which is, don't forget this except. Don't forget this except. Okay. So please remember, appendicitis, you all understand this is appendicitis, right? This is acute appendicitis. Acute appendicitis in a child, the investigation of choice in child is graded ultrasound. You need to do a phases, you'll slowly push the bowel loops and do ultrasound, the graded ultrasound. In adults is CECT. And we all know CT is more sensitive. Because this is a 10-year-old boy, they did ultrasound, and on ultrasound, what do you see? A blind ending tubular structure, which is showing aperistalsis. Because it's inflamed bubble, it will not show peristalsis. It will also show dilated lumen with wall thickening. You will have dilated lumen also with wall thickening. But you cannot compress. It is not compressible. It is not compressible. This should be the answer because it is except. This should be the answer. Remember, veins will show compressibility. This is called winking sign. But an inflamed bowel will not get compressed. Okay, an inflamed bowel will not get compressed. Veins will show compressibility. lack of compressibility of veins should make you think of DVT, deep vein thrombosis. Okay, let's try the next one, guys. Chalo, try the next one. A young child presents with seizures refractory to medication. He is mentally retarded and shows focal neurological deficits on examination. He has a peculiar purple-red mark on the one side of the face since birth. CT scan is obtained and the image is given below. What is the likely diagnosis? All are true about these conditions except. So here is asking all are true except. Try to understand this question. A young child is there with seizures, refractory to medication. He is mentally retarded and shows focal neurological deficits. He is having a peculiar red color mark on one side of his face. What do you think is this? What is this? First of all, this is port wine stain. And what is the CT showing you? You are seeing this leptomeningeal, right? Vascular malformation. You see this irregular calcification called as tram track calcification on a CT scan. Tram track calcification on CT. And if you compare the brain parenchymas on the right side and the left side, you are seeing there is hemiatrophy of the brain. Hemiatrophy of brain. One side of the brain is atrophic, right? If you can see, the right side is atrophic compared to the left side. All of this is suggestive of Sturge-Weber syndrome. Sturge-Weber syndrome. Sturge-Weber syndrome. Sturge-Weber syndrome, you will have the involvement of trigeminal, okay, trigemino-encephalic vascular malformation. So the trigeminal area is involved. So you'll have the trigeminal area involved, facial lesion involving the trigeminal nerve, right? So the trigeminal area will be involved, trigemino-encephalic vascular malformation. The port wine stain is in the trigeminal area. The cortical gyriform calcifications and glaucoma, yes, this will also be present because, you know, it is having trigemino-encephalic vascular malformation. There will be this calcification, the tram track calcification along the gyri, as well as you have glaucoma because of ophthalmic division of trigeminal nerve involved. Hemiatrophy of the brain, yes, on the same side of port wine stain, trigemino-encephalic. So on the same side, there will be vascular malformation which is causing hemiatrophy of the brain. And it is sporadic. It is not autosomal dominant. It is sporadic. So except is asked, the answer should be C, right? It is C. It is sporadic, not autosomal dominant, right? So this is all about Sturge-Weber syndrome. Sturge-Weber syndrome. Okay. Answer this. A 65-year-old male presents with seizures. He has recently developed headache and frequent vomitings. On examination, he has papilledema. So this is an elderly patient. Seizures, has developed headache and frequent vomitings. On examination, he has papilledema. CT scan head shows a hypodense area in the left frontal lobe. MRI shows irregular lesion with necrotic areas and thick peripheral enhancement. There is infiltration in the genu of corpus callosum and extending into right hemisphere. No calcification is seen. What is the most likely diagnosis? Very good, Aiza, Akanksha, right? Divya, ISM, Basit, very good, Srinket, Ashraf, very good. All of you are right. This is glioblastoma multiformis. Please remember lesions invading corpus callosum. Please remember 2 lesions at least invading corpus callosum. Glioblastoma multiformis as well as CNS lymphomas. CNS lymphomas. So these are the lesions that can invade the corpus callosum. Lesion invading corpus callosum are glioblastoma and CNS lymphomas. Remember these 2 things. Okay, this is very important for your exam. All of you should know this thing. Should not do this wrong. A 30-year-old patient presents with sudden onset of high fever, headache, confusion and seizures. MRI shows hyperintensities in bilateral temporal lobes. What is the likely diagnosis? What do you think is this? Please remember, when temporal lobe involvement, fever patient with temporal lobe involvement is given, this is herpes simplex encephalitis. Most common lobe involved in herpes simplex encephalitis. Herpes encephalitis. This is temporal lobe. Cannot do this wrong. Right? Cannot do this wrong. The most common lobe involved in herpes simplex encephalitis is what? Temporal lobe. You should not do this wrong. Let's look at the next one. Okay. A 35-year-old female with headache, MRI image is given. What is the most likely diagnosis? What do you think is this image showing you guys? So it's a middle-aged female with headache and MRI is given. Can you see the image here? It is broad-based towards the dura, and you can see a dural thickening also adjacently. So this lesion which is broad-based towards dura, showing dural thickening, more common in females. Females more common than males. This is showing dural tail sign, right? Dural tailing is there, and there will be also be mother-in-law sign. Mother-in-law sign. Mother-in-law sign is early to come. Contrast shows early enhancement, and late to go, delayed washout. This is meningioma, right? So meningioma. Meningioma is more common in females because of the hormone receptor, progesterone receptor positive. And multiple meningiomas, which will be seen in which condition? Multiple meningiomas, किस में देखेंगे? Multiple meningiomas. These are features of NF2. Remember, miss-me lesions, multiple inherited schwannomas, meningiomas, ependymoma. So multiple meningiomas are features of NF2. Multiple inherited schwannomas, meningiomas, and ependymomas. These are features of NF2. So this is what is meningioma. So remember these two signs in radiology, dural tail sign and mother-in-law sign. Don't forget these with meningioma. Okay, don't forget these with meningioma. Okay. What is this one, guys? A 22-year-old female with primary infertility underwent HSG examination. What is the likely diagnosis? Is it unicornuate, bicornuate, septate, or didelphus? Very good. Priyanka, look at it carefully again. Look at it carefully, Yogesh, right? So this is two separate catheters, two separate, vagina. This is didelphus. You are seeing two separate catheters, two separate vaginal openings. This is didelphus, okay? So, but by the way, what is the gold standard investigation for uterine anomalies? Gold standard for uterine anomalies. Uterine anomalies. What is the gold standard for uterine anomalies? This is not HSG. What is this? Gold standard for uterine anomalies. Not HSG. It is hysteroscopy, endoscopy. Hysteroscopy with laparoscopy. Endoscopy from inside and outside. Endoscopy from inside and outside. Okay, hysteroscopy and laparoscopy. The imaging investigation of choice is 3D ultrasound. But remember, MRI is more sensitive or problem solving, right? So the imaging investigation, only 3D. When 3D is mentioned, then only mark. Don't write ultrasound. Only 3D is given. That is the imaging investigation of choice. MRI is useful when 3D ultrasound does not give you a proper diagnosis. 3D ultrasound is the primary modality. If 3D ultrasound is equivocal, then you go for MRI. So which is more sensitive? MRI is more sensitive because it is used when 3D ultrasound does not give you the confirmation. But what is the gold standard? Best confirmatory. If they say gold standard or best or confirmatory, it is hysteroscopy or and laparoscopy, endoscopy from inside and outside. Okay, so for all of these uterine anomalies. Okay, the next one, a female on antenatal scan is told that there is a problem with her fetus. The following ultrasound image is obtained. What is the likely diagnosis? So can you see there are facial bones, but you don't see the cranial vault. You don't see the cranial vault. So when you see acrania, there is no cranial vault. You see acrania. This is anencephaly. So this is acrania, absent cranial vault. This is anencephaly, and this shows you frog eye appearance or Mickey Mouse appearance on ultrasound. Mickey Mouse appearance. Okay. What does this image show you? This is a HSG image, and you see there is bilateral distended fallopian tubes without any free leak of contrast, right? So this is bilateral hydrosalpinx. Okay, so this is bilateral hydrosalpinx. There is ostial blockade giving this bilateral hydrosalpinx. Identify this image, guys. Identify this image on the modality. First of all, how are the vertebrae? How are the vertebrae? White or black? The bones are black. So black means MRI. And this is showing the kidneys, showing this polycystic kidney disease. This is MRI of polycystic kidney disease. MRI of polycystic, very good, very good. MRI of polycystic kidney disease. Now, let's see how this one, 27. Can you answer this? Identify the site of foreign body as shown in the image. What is this? Is it in the trachea? Is it in the esophagus, mediastinum, or pleural cavity? Very good. Uh, Still some people are getting it wrong. Let me zoom it for you. Can you try now? Can you try now? Trachea, which one is it? Is it in the trachea? It's very good. Now I get more correct answers. You can see here, this is the uh, foreign body that is posterior to the tracheal stripe. This black area is the trachea. Trachea has air, right? So this is the trachea, and it is posterior to the tracheal stripe. So when it is posterior to tracheal stripe on the lateral radiograph, this is coined in the esophagus. So this is esophagus, foreign body in the esophagus, right? Okay. Next one. Where do you see colon cutoff sign? A female with upper abdominal pain radiating to back, and there is colon cutoff sign. This is acute pancreatitis, right? Acute pancreatitis has colon cutoff sign. I hope you remember that. Okay, look at this question. A 60-year-old male presents with multiple bone pain, anemia, calcium levels are elevated, right? So normal is 9 to 11, it is high here. Albumin globulin ratio is deranged, elevated globulin, Benz-Jones proteins are also seen. X-ray skull is given. What is the likely diagnosis? This is raindrop skull, feature of multiple myeloma, raindrop skull, right? So this is multiple myeloma. Remember, in multiple myeloma, few things that you need to remember is how to identify the clinical picture. It's usually elderly patients, right? Usually above 60 years. And remember cramp, right? Hypercalcemia, right? Normal is 9 to 11, right? So this is much more, hypercalcemia. Renal failure, they'll give you creatinine levels. Anemia, or they'll give you hemoglobin decreased. Bone pain. All of this is multiple myeloma, and it shows you raindrop skull. And in multiple myeloma, please remember, there are punched out lytic lesions. You have punched out lytic lesions. Because you have lytic lesions, these are not seen on bone scan. Okay, so bone scan is not useful. Bone scan is not useful. Bone scan only picks up osteoblastic activity. Osteoblastic activity. Right? It only picks up osteoblastic activity. You cannot use bone scan for multiple myeloma, right? I hope the rest of the things from your pathology and medicine, you know a lot about multiple myeloma. Let's come to the next one. Okay, identify the marked bone on the given radiograph. What do you think is this? What do you think is this showing you? What is the arrow pointing to? Which bone? Calcaneus, cuboid, navicular, or talus? This is navicular bone, right? So this is navicular bone. So this boat-shaped bone, this is the navicular bone. And anterior to that, you have medial cuneiform. This is the medial cuneiform. Then you have the intermediate, then the lateral cuneiform. And this bone on the other lateralmost part, this is cuboid, right? So this is the cuboid bone that you have. So this is how the tarsal bones are there. Navicular, medial cuneiform, intermediate, lateral, and the cuboid bone on the lateral side. These are the tarsal bones you should need to pick up. Okay. Look at this question. Is the speed fine? First of all, please tell me, are you okay with the speed? Or do you want me to increase? Do you want me to decrease? Are you comfortable? I hope by this time you're all well aware and ready for the exam. So I hope just asking if the speed is comfortable for you. Perfect. Okay, fine. Hello. A female has a cervical cancer or a bladder cancer given in the question and underwent radiotherapy. Which is the most radiosensitive organ among the following? Remember, among the following, obviously, the gonads are radiosensitive. The most radiosensitive tissue, कौन सा है body में? Most radiosensitive tissue in our body is bone marrow. Most radioresistant tissue in the body, this is CNS. Most radiosensitive organ is gonads. And radio-resistant organ is your vagina, stratified squamous epithelium of the vagina. Right? There is a law called as law of Bergoni, which says that the undifferentiated cells with high mitotic activity, undifferentiated cells with high mitotic activity, these are radiosensitive, right? High mitotic activity, these are radiosensitive. And whereas cells which are well differentiated, with low mitotic activity are resistant. This is called as law of Burgoni. And that is the reason the bone marrow which has stem cells, which is having high mitotic activity, gonads which has stem cells and high mitotic activity, this is radio sensitive. Now let's look at the next one here. Identify the investigation given here. Look at the image. How are the bones? How are the hip bones, right? The pelvic bones, they are dark. And what do you see here? There is mucosa that is seen clearly. There is distension of the bubble and the mucosal rugae are seen better. This is, what do you think this is? How are the bone? Bone white है या black है? अब बताओ bone कैसा है? Bone कैसा है? Black है. So this is MR enteroclysis. MR enteroclysis. So be careful on the image. There is distended bubble on MR enteroclysis, right? You'll see the mucosa better. And look at the bone. Bone is white, CT enteroclysis. I showed you in the image of GA, right? GA radiology in the beginning of the class. I showed you how CT enteroclysis, the bone will appear very bright and right, very denser, darker. Will be MRI, denser will be CT scan. White है, dense है तो CT है. Dark है तो MRI है. So this is MR enteroclysis. Okay. Let's look at this thing. A chest X-ray from a patient of COVID-19 would show. What would it show? What did it show? How to differentiate enteroclysis and barium meal follow through. Barium meal follow through, you don't see, you will see only lumen. You will not see mucosal rugae. ये चीज important है. Enteroclysis, you use a double contrast. You distend the bubble, right? You see, give fluid and you distend the bubble so that the mucosal rugae are seen. Barium meal follow through will not show the rugae clearly. Just you see the lumen, right? Barium ka lumen dikhega, not the rugae. So if you are seeing this rugae, and barium would be white, right? It would not be showing this dark and fluid signals of MRI. So the barium meal follow through would be lumen that is seen. You will not see rugae much clearly. Are you okay with that, Bhavya? Next one. So yes, all of you are answering it correctly. Peripheral, bilateral, ground glass opacities, right? This is due to diffuse alveolar damage that occurs. The diffuse alveolar damage that occurs in COVID-19 that produces this. On the chest X-ray, you will see bilateral, peripheral, ground glass opacities. Okay, peripheral bound. These are the earliest. The ground glass opacities are the earliest and the most common findings that you see in COVID-19. Okay, COVID-19. Bilateral, peripheral, multifocal ground glass opacities will be there. Okay, what is this? A female with infertility and ultrasound image is given. What is the likely diagnosis? Is it PCOS, OHSS, theca lutein cyst, chocolate cyst? This is easy. This is OHSS, right? So you're having female with infertility and you are seeing bilaterally enlarged ovaries. Bilaterally enlarged ovaries. And how are the cysts? They are large cysts that you have. And how is the stroma? The stroma is thin, spoke wheel like, spoke wheel stroma. Spoke wheel stroma. This is all OHSS. Generally, it will be a female receiving HCG injections for infertility treatment, right? That is how you have. And you'll also see, effusions, third space collections in OHSS. PCOS वैसा नहीं रहेगा. PCOS का image कैसा रहेगा? PCOS, the stroma will be thick and you'll have peripheral small follicles, ring of pearl appear. So they'll have a central thick stroma, PCOS. Central thick stroma will be there. Peripheral follicles will be there. And these follicles are not very big. These are less than 10 mm, more than 20 in number. And the ovarian volume will be more than 10 ml, right? The volume is increased because of the thick stroma, right? Thick central stroma will be there. So looking at the stroma, you can tell whether it is PCOS or OHSS. OHSS will have spoke wheel like, tire wheel like stroma, whereas your PCOS will have a thick central stroma with peripheral small follicles. Large cysts is seen in OHSS. Small cysts are seen in small follicles, not even a Graafian follicle, less than 10 mm are seen in case of PCOS. Okay, that is how we differentiate both PCOS and OHSS. So answer here should be OHSS. When do you call it theca lutein cyst? When you have endogenous HCG. When you have endogenous HCG increased. Like in case of multiple gestation, if the same image is given and they say this is a female with molar pregnancy or with a female of multiple gestations. So when you have endogenous HCG is elevated, then the answer should be theca lutein cyst. But here this is a female with infertility. She must be receiving HCG injections, exogenous HCG. So when you have exogenous HCG, that is OHSS. If you have endogenous HCG, then the answer would be theca lutein cyst. So here the answer is OHSS. Right, answer this 35th question, guys. A patient presents with high-grade fever, chills and cough with sputum, radiograph is shown. What is the likely diagnosis? Very nice. All of you are answering it correctly. Please remember, pneumonia to hai, but look at the image carefully. This has been asked many times in your FMG exam. This is your minor fissure. This, okay, let me draw it for you. How the minor fissure and major fissure. This here is the major fissure. This here is the minor fissure. So this is the minor fissure and this is the major fissure that you have. Right. So this becomes the upper lobe. This overlapping the heart. This is middle lobe and here posteriorly is the lower lobe. So you're given a frontal radiograph and a lateral radiograph. You see the opacity which is in close contact with right heart border and it is also overlapping the cardiac shadow. So this silhouetting of the right heart border, this is your right middle lobe consolidation, So it's very important to understand how the lobes of the lung are. Right middle lobe is in close contact with the right heart border. It overlaps the cardiac shadow. This is middle lobe consolidation, right? Next thing, a 65-year-old hypertensive patient, BP is very high, CT scan of the head is done. You can see the CT of the head and you are seeing a hyperdense area inside. This is very easy. This is putaminal bleed, the most common site of hypertensive bleed, right? So this is putaminal. Can you tell me what is the cause of hypertensive bleed? What is the cause of hypertensive bleed that we have? This is rupture of, what is this occurring due to? What is this occurring due to? Rupture of Charcot-Bouchard aneurysms. Charcot-Bouchard aneurysms. Right? So this is rupture of Charcot-Bouchard, not Berry aneurysms, Charcot-Bouchard aneurysms. Okay, hypertensive bleed. The most common site of hypertensive bleed is putamen. Okay, the putamen. Okay. Look at this one, 37. A patient with recurrent UTI, IVP image is given. What is the location of insertion of ureter arising from left superior pelvis? First of all, look at here. This is the right side. This is the left side. On the left side, you have two ureters, one superior ureter and one inferior ureter. So this is a duplex kidney. Remember this duplex kidney or duplication system. It will have three kidneys. In duplex kidney, we don't have two kidneys. In duplex kidney, we have three kidneys. Okay, so a normal kidney on the normal side and duplication on the other side. And duplication system, they follow a rule called as Weigert-Mayer rule. Okay, so the rule is called as Weigert-Mayer rule. Just remember with this mnemonic called SEMO, right? Weigert-Mayer rule. So what does the SEMO say? The superior ureter inserts infiromedially and is prone to obstruction in the form of ureterocele. So this word will help you. SEMO, you remember, superior ureter inserts infiromedially and is prone to obstruction. So infiromedially, there is ectopic insertion is seen, ectopically. The opposite is correct for lower ureter. The lower ureter inserts superolaterally, normally or orthotopic or normal, and is prone to reflux. So if you remember SEMO, right opposite is correct for lower ureter. So what is the correct answer here? What do you think is the correct answer here? A, B, C, D. So he's asking you about what? Location of superior ureter. How does it insert? So it should insert infiromedially. Superior ureter is SEMO, infiromedial. So it should be inferior and medial, right? So inferior and medial. So answer should be A. Next. What is the marked structure on the CT scan here? What is the orange arrows pointing to? This is easy. This is pointing to optic nerve, right? So this is simple. What about this structure here, guys? What is this structure pointing to? Medulla, pons, midbrain, spinal cord. Can you answer this one? Very good. You can see there is interpeduncular fossa, crus cerebri interpeduncular fossa, right, like this. So this is the interpeduncular fossa that you are seeing. This is midbrain. Important landmark of pons is basilar artery. Basilar artery will be in front of pons. If it was pons, in front of pons, you will see the basilar artery. Okay, you will see the basilar artery. So because you don't see the basilar artery here and you see the interpedunclar fossa, the correct answer here is what? Midbrain. Okay, midbrain. Okay, answer this one. A 45-year-old male with heart disease undergoes a chest X-ray. What is the diagnosis? So, what do you think is this patient suffering from? What is this patient having? Okay, a patient with heart disease and a chest X-ray. What is this valve that you have here? Is it a aortic valve, mitral valve, pericardial calcification, or placemaker that you have? This is mitral valve. So draw imaginary line from the left hilum to right cardiophrenic angle. If it is below it, it is mitral valve. If it is above it, that would be aortic valve. So this is how mitral valve and aortic valve can be differentiated. A mitral valve will be below this imaginary line between the left auricle. So from the left auricle to right cardiophrenic angle, right? So if you draw imaginary line between the left auricle or the left hilar areas till the right cardiophrenic angle, if it is below it, it is your mitral valve. If it is above this imaginary line, this is aortic valve. So this answer should be mitral valve. What is this? The given skull X-ray finding. This is easy. All of you should answer this. Can you answer this one? 41. Given skull X-ray. Look carefully. Look carefully. You can see lot of, enlargement of the diploic spaces of the skull, producing this hair on end appearance, right? So this is hair on end appearance or crew cut appearance. Hair on, cannot do this wrong. Hair on, and I'm not happy with this being done wrong. Okay, hair on end or crew cut appearance. Crew cut appearance. The first answer should be thalassemia. If that is not there, then you can answer severe hemolytic anemias like sickle cell anemias. But your first answer, only severe hemolytic anemias, not the routine sickle cell anemia. Only severe hemolytic anemias and especially thalassemia produces crew cut appearance or a hair on end appearance. Okay, please remember that thalassemia is the answer here. This is easy. You can see the football sign and you can also see the inverted V sign. Inverted V sign, which is nothing but the lateral umbilical ligaments that you are seeing. Lateral umbilical ligaments. So this is suggestive of pneumoperitoneum or hollow viscous perforation. Pneumoperitoneum, hollow viscous perforation. Okay. Answer this one, 43. Answer 43, guys. Answer 43. What is this? So you are seeing a crescentric collection, right? A concavo-convex, which is crossing sutures, not crossing the midline. And if you see, there are two different densities here. More whiter one, this is acute. This dark one is chronic. So it is crossing sutures. It is crossing the parietal bone, the frontal bone, right? It is going through it, but not crossing the midline. It is crossing the sutures, crosses sutures, but does not cross midline. It is concavo-convex, concavo-convex, right? So crescentric. This is all subdural hematoma. So you have acute on chronic, right subdural hematoma in this image. So the answer here should be subdural hematoma, right? Acute bleeds are hyperdense. Acute bleeds are more white, hyperdense. Chronic bleeds are hypodense, darker. Okay, chronic bleeds are hypodense. So that is how you have it. Look at this image. What is this IVP image showing you? 44. Simple. You can see, if you see carefully throughout the image, you can see this cobra head or adder head appearance. This is bilateral uretrocele, cobra head or adder head appearance. Right? So this is bilateral uretrocele. Okay. This is simple again. A female with fever, weight loss, elevated ACE levels, hilar lymphadenopathy. This must be sarcoidosis. You are seeing bilateral hilar lymphadenopathy. This is sarcoidosis. We have discussed that. Now, answer this one, 46. What is this vessel? Very nice. All of you are answering it correctly. Very good. So here you can see this is the aorta. This is the inferior vena cava. This is the portal vein. Portal vein travels transversely in the liver. Right? Portal vein travels transversely in the liver. Right? So this is the portal vein that you have. Right? So portal vein. Okay. Now, this is FFG, previous FFG question. Try to answer this 47. A patient with prostate cancer receives sequential radiotherapy at a dose of 1.8 to 2.4 gray for 5 days every week for 5 to 7 weeks. This is called as. Very good, Yogesh Bhapia. Right? So, if you see that there is a regular or fractionated radiotherapy, this is Monday to Friday OD dose, right? This is 5 fractions per week, 5 fractions per week. So, the regular or conventional radiotherapy, you will give 5 fractions per week. Hypofractionated will be less than 5 fractions per week. This will be usually palliative, given for bone metastasis. Hyperfractionated will be more than 5 fractions per week. So, basically 5 fraction A, less than 5 fraction A, more than 5 fractions A per week. Okay. And how this is achieved? By TID doses or BD doses, right? So, that is how you have hyperfractionated. Accelerated, when you have much faster delivery that is done. Okay, you will complete the whole radiotherapy much faster within 4 to 5 weeks, right? You're completing the entire radiotherapy. And this accelerated radiotherapy, especially chart, that is continuous hyperfractionated accelerated radiotherapy. Continuous means all 7 days you give. Hyperfractionated means BD or TID doses you give, more than 5 fractions per week. Accelerated, you cover very fast, within 4 to 6 weeks you cover the entire radiotherapy. And this chart is mainly used for non-small cell lung cancer, non-small cell lung cancer. So remember, if you are giving 5 fractions per week, okay, if you are giving Monday to Friday, right, every week 5 fractions you are giving, this is what is regular or fractionated radiotherapy. Okay, 5 days a week, 5 fractions, right? So this is regular or fractionated radiotherapy. Let's come to the next one. Again, this is what we discussed also. A 2-year-old child, sudden onset of breathlessness, wheezing, decreased breath sounds in right lung. Chest radiograph shows diffuse opacity. Here it is saying either a opaque hemithorax or a lucent hemithorax. Previous image I showed you lucent hemithorax. यहाँ पे opaque hemithorax बोल रहा है. Either you have a opaque hemithorax or a lucent hemithorax. The first thing should be foreign body. The first thing should be foreign body. This age group is very prone to develop foreign bodies. Okay, this child of 2 to 3 year age group is more prone to explore things and keep things in his mouth. So it's important age group for foreign bodies. Okay, 49. Where do you see prophylactic craniospinal irradiation done? In which cancer we do prophylactic craniospinal irradiation? Prophylactic craniospinal irradiation. Very good, right? Very good. This is done for small cell lung cancer. So cancers which have early CNS involvement. Which cancers will have early CNS involvement? Medulloblastoma. We do craniospinal irradiation, medulloblastoma. Medulloblastoma, because of drop metastasis or CSF spread, right? We have prophylactic craniospinal irradiation, right? So in the brain and the spinal cord, if there is a tumor in the fourth ventricle and it goes and forms small metastasis, sugar coating, you call it sugar coating also, right? On the CSF and the spinal cord, this is medulloblastoma. Non-Hodgkin's lymphoma, not Hodgkin's, non-Hodgkin's, especially the diffuse B-cell lymphomas, they can have early CNS involvement. ALL, acute lymphoblastic leukemia, has CNS, mediastinal mass, CNS involvement, lymphoblastic leukemia, and small cell lung cancer, and also for small cell lung cancer, small cell lung cancer, small cell lung cancer. So this small cell lung cancer also has, hematogenous spread, early hematogenous spread. You know about the Azopardi effect, right? Small cell lung cancer. So all of these 4 cancers, remember, they have early CNS involvement. For them, we have to go for prophylactic craniospinal radiation. And if I ask you, what is the most common hormone deficiency that develops after craniospinal irradiation? Anybody can answer. What is the most common hormone deficiency after craniospinal irradiation? Which hormone is mostly reduced after you give craniospinal radiation? So imagine this patient has undergone craniospinal radiation. What is the most common hormone deficiency that you have? The most common hormone deficiency after craniospinal radiation is your, very nice Sindhuja, aspiring doctor, Yogesh, Pullman, very nice Sara. This is growth hormone. Growth, very good Danish. growth hormone, right? So this is growth hormone that is deficient. Next. Okay. Identify the given X-ray. What do you think is this X-ray showing you? Very nicely, we covered 50 questions very fastly. Okay, which one is this? Very nice. This is simple. You are seeing horizontal air fluid level. So horizontal air fluid level. Horizontal air fluid level. This is hydropneumothorax. If it was effusion, you will see meniscus sign and Ellis curve. So if you have something like this, a meniscus-like area and a concave upward curve, that would be pleural effusion, right? So pleural effusion would be having this meniscus sign and Ellis curve, but here it is more horizontal. So horizontal air fluid level, this is hydropneumothorax, hydropneumothorax. So the answer should be hydropneumothorax here. So we have covered some 50 questions. I'll again do the questions again, okay? Again towards the end of the class, okay? We'll do some questions. Let me just come back to some important emergencies again, then I'll come back to the questions. What do you want to do? Do you want to do the questions or you want to look into some theory also? क्या करने का मन कर रहा है आप लोग का? Shall we finish off some questions now? Let us do some theory part and then again I'll come back because some images complete karte hain, important images. Okay, I'll come back to the questions again. Okay, I'll come back to the question. Briefly, we'll finish this fastly and we'll come back. Look at this image. What do you see on this image? Post-intubation X-ray, and you can see this is the endotracheal tube. And the tip of the endotracheal tube is gone into one of the main bronchus. It has gone into the right main bronchus. So this is faulty insertion of endotracheal tube. It should not go into the main bronchus. Normally, the tip of the endotracheal tube should be at least 5 centimeters from the carina. This distance should be more than 5 centimeters from carina. But if it has gone into one of the main bronchus, right? It has gone into one of the main bronchus. This is faulty insertion. So you should identify a faulty insertion of endotracheal tube. Look here, there is a neonate with frothing, and you are seeing this coiling of nasogastric tube. A neonate with frothing, and you are seeing coiling of nasogastric tube. What do you think is this? This is trachoesophageal fistula. Very good. This X-ray was given in the exam. Tracheal fistula will have coiling of the nasogastric tube with frothing in the newborn. Okay, look at this X-ray. You are seeing absent bronchovascular marking. You are seeing this visceral pleural line and a deep sulcus sign. You are seeing a deeper sulcus compared to the opposite side. So absent bronchovascular marking, visceral pleural line, deep sulcus sign. Deep sulcus sign, this is especially seen on supine patients, supine chest X-rays. This is suggestive of pneumothorax. And what is a tension pneumothorax treated with? What is the treatment that you do for tension pneumothorax? You go for a wide bore needle, wide bore or large bore needle. How much gauge? You use a 14 gauge needle, followed by ICD. Right, followed by ICD. So that is the tension pneumothorax. Okay. Where do you see seashore sign on ultrasound, on lung ultrasound? Where do you see seashore sign? Seashore sign on lung ultrasound. So you see this lung ultrasound showing seashore sign. This is normal lung. Very good. Normal lung. And where do you see barcode sign or stratosphere sign? Barcode or stratosphere sign. You see lot of these lines, lot of these white lines, which are horizontal, right? Not vertical. There are horizontal white lines that you're having. This barcode sign or stratosphere sign is sign of pneumothorax. And what is the point of transition between them? The point of transition between them is called as lung point. And that is pathognomic. Lung point is pathognomic of pneumothorax. So imagine this is the lung. This is the pneumothorax that we have. And I'm doing ultrasound here. So this will show seashore sign. This will show barcode sign. So here you will see seashore. Here you will see barcode. and in between you see a point of transition, right? The point of transition. This point of transition is called as lung point, a pathognomic finding of pneumothorax. Okay. Now, what do you think is this CT scan image showing you? This is the right lung, this is the left lung, and you can see this is the air that is anterior to the lung, right? So the anterior to the left lung. So this is how you have pneumothorax, right? On a CT scan. The investigation of choice for air anywhere is CT, right? So you see air anterior to the lungs. What about this? What is this image showing you? What is this image showing you? Here you're seeing air around arch of aorta, around trachea, right? You can see air around the trachea also. So what do you think all of this is? What do you think all of this is? Air around the arch of aorta, air around the trachea. What do you think is this? What do you think? Is it pneumothorax, pneumoperitoneum, pneumomediastinum, pneumopericardium? What do you think all of this is? This is pneumomediastinum. Very good. Pneumomediastinum. This is pneumomediastinum. Let's move forward. Now look at here. There is a sign called as fallen lung sign. Fallen lung sign. Anybody? Where do you see fallen lung sign? Fallen lung sign. Fallen lung sign is feature of fracture of bronchus. Fracture of bronchus. So whenever we have fracture of the bronchi, the lung falls. The lung falls inferiorly and laterally, right? It falls inferiorly and laterally. This is called fallen lung sign. Just remember this trauma sign, okay? One of the important signs that you see in trauma, the fallen lung sign. Instead of collapsing towards hilum, if it was pneumothorax, it would have collapsed towards the hilum. But instead of collapsing, if it is inferiorly and laterally, that is called as a fallen lung sign. Both of them occur in trauma. So if you see the hilum collapsing, if you see the lung collapsing towards the hilum, that is a pneumothorax. But if you see the lung collapsing inferiorly and laterally, right, falling inferiorly and laterally, that is called as fallen lung sign, feature of fracture of bronchus. Just theory based question yaad rakh lena. Fallen lung sign is fracture of bronchus. Okay, fracture of bronchus produces fallen lung sign. Okay. This is a patient with sudden onset of respiratory distress, and when you're looking at the X-ray, you're comparing the lung fields. You're seeing more vessels here, but there are less vessels in that area. The star marked area, there are less blood vessels. There is pulmonary oligemia in that area, pulmonary oligemia. What is pulmonary oligemia called, guys? What is pulmonary oligemia called? Westermarck sign. This is Westermarck sign. And what is this peripheral wedge-shaped area called? This peripheral wedge-shaped area is called as Hampton's hump. Hampton's hump. So these Westermarck sign and Hampton's hump, these are features of pulmonary thromboembolism. Pulmonary thromboembolism. What is the investigation of choice? Here you can see here, there is a filling defect. Can you see this filling defect here? This filling defect that you are noting, this is your saddle embolus that you are seeing, right? So this is the saddle embolus that you are seeing at the bifurcation of the pulmonary artery. What is the investigation of choice for pulmonary thromboembolism? CT angiography. CT angiography is the investigation of choice. CT angiography, right? So this is pulmonary thromboembolism. Remember Westermarck sign, Hampton's hump, the identify saddle embolus on the CT scan. Also, please remember CT angiography is the investigation of choice. Important, pulmonary thromboembolism. Then let's understand how to label the blood vessels on a CT chest. So in looking at the CT chest, anteriorly we have ascending aorta, posteriorly we have descending aorta. This is right side, this is left side, this is anterior part, this is posterior part. To the right of ascending aorta, you are seeing superior vena cava. To the left of ascending aorta, you are seeing main pulmonary artery. So remember, this is the arch of aorta, right? Ascending aorta, descending aorta. You have the pulmonary artery like this. You have the right and left brachiocephalic veins uniting and forming superior vena cava. So if I take a cut section here, you will see anteriorly ascending aorta. To the right is superior vena cava. To the left is main pulmonary artery, dividing into right and left branches. So you should know which is right side, which is left side. On the CT scan, always remember the patient is lying down with his legs facing you. So this is the right side, this is the left side. This is the anterior part, this is the posterior part. So to the right of ascending aorta, is superior vena cava. To the left of ascending aorta is main pulmonary artery. So just understand the orientation correctly. Now, look at here. I hope you can see a double lumen with intimal flap, right? So double lumen with intimal flaps. This is aortic dissection. Aortic dissection. This is involving ascending aorta. This is involving the arch, and this is involving the descending aorta. And what is the most common site involved? What of all of them, which is the most common site of involved of aortic dissection? Acute onset of chest pain radiating to the back, patient of Marfan syndrome or uncontrolled hypertension. What is the most common site of involvement? Ascending aorta, arch of aorta, or descending aorta, which is the most common involvement? If at all there is ascending aorta involvement, that is called Stanford A. Stanford A. And Stanford A is more common, right? And because it is ascending aorta, it is involving the coronaries. So surgical management should be done. Surgery should be done for ascending aortic dissection. Whereas descending aorta involvement, this is called Stanford B. And we generally go for medical management. Right? Okay. Here, you can see the caliber of the aorta is increased, right? This is aortic aneurysm. Aortic aneurysm. Just the caliber is increased. This is aortic aneurysm. Aortic aneurysm most commonly involves infrarenal aorta. Infrarenal aorta, the most common, the abdominal aorta. So dissection most common is ascending aorta. Dissection most common is ascending aorta, and aneurysm is infrarenal aorta. Can I ask you what is this white arrows pointing, guys? What are these white arrows pointing to? Can you tell me what is this white arrows pointing to? What are these white arrows pointing to? Can you tell me what is this? No, no, they are not kidneys. They are not kidneys. These are psoas major muscles. Okay, so these are psoas, paravertebral muscles, psoas muscles. These are psoas. Okay, so these are paravertebral muscles that you have. These are your psoas major muscles. Okay, do not confuse. They are not kidneys. They are the paravertebral muscles. Kidneys are not so close to the vertebral body, right? So kidneys will not be kissing the vertebral body like that. These are the paravertebral muscles, the psoas muscles. Okay, so differentiate that. Now look at here. This is the aortic aneurysm which has undergone rupture. So you can see this hematoma around it. You can see this collection of hematoma around this. This is rupture of abdominal aortic aneurysm, or fatal complication that you have with aortic aneurysm is a rupture, and you see this hematoma that is seen around this aneurysm. So this is rupture of abdominal aortic aneurysm. Okay, what is this technique that is being done here called? What is this technique being done here called? This is FAST. What is the full form? Focused assessment with sonography for trauma. So you take 4 views. The first view is a subxiphoid view, also called as subcostal. And this will look at the heart and the pericardial collection. So this first view, or the subxiphoid view, is for pericardial collection. This is for pericardial collection. The second view that we take is the right lumbar, also called right upper quadrant view. And here you see the liver and the kidney in between. If any collection is there in the Morrison's pouch, you can see it in the right upper quadrant view or right lumbar view. And because Morrison's pouch is the inferior most portion of the peritoneum, this right lumbar view is the most sensitive view, for hemoperitoneum. So first view is different, most sensitive view for hemoperitoneum is different. The Morrison's pouch is the inferior most portion of the peritoneum in a supine patient, in a trauma patient. When you are doing ultrasound, he is supine. So the most inferior portion of the peritoneum in a supine patient is a Morrison's pouch, the hepatorenal space that is seen in the right upper quadrant view. So the most sensitive for hemoperitoneum is right upper quadrant view. The first view that we do is the subxiphoid or the subcostal view. Clear? The other ones, we have the left lumbar as well as the pelvic views we have. This is FAST. So here you can see a pericardial collection which is causing right ventricular diastolic collapse, that is compressing the right ventricle. So when you're doing fast or e-fast and you see pericardial collection, you're seeing a pericardial collection causing right ventricular diastolic collapse. What do you think this is? Is it just pericardial effusion or something else? Is it just pericardial effusion or something else that you're looking at? Pericardial collection with right ventricular diastolic collapse. If you're having a right ventricular diastolic collapse, what do you think is this? This is cardiac tamponade, right? So cardiac tamponade. Okay, so the Beck's triad will be there. Hypotension, right? Increased GVP and muffled heart sounds, right? All of this is Beck's triad. So this word is important. If you're seeing on echocardiography right ventricular diastolic collapse, a pericardial collection causing a right ventricular diastolic collapse, please think of cardiac tamponade emergency. Look here, this is the liver, this is the kidney, and in between you're seeing a collection in the Morrison's pouch. This is what is called as fast positive. Fast positive. Okay, so the most sensitive location to look at hemoperitoneum, most sensitive is the Morrison's pouch, the right upper quadrant view, right? The right upper quadrant view or the right lumbar view to look at hemoperitoneum. Look at here, this is CT scan. So this is the vertebral body which is white. So this is CT. This is right kidney, left kidney. What is this star mark I have kept? Anybody? What is the yellow star that I have kept? What is the yellow star that I have marked here? What do you think is this structure? What is this yellow structure? Yellow star? Very nice. This is on the right side. So don't confuse it with spleen. This is the liver that you have. So you're seeing collection around the liver. This is the spleen here. You're seeing collection around the spleen. So you're having collection around the liver, collection around the spleen. So which organ is damaged? In a trauma patient, this is an RTA patient, and you have done a CCT. You can see contrast inside the aorta, right? Compare the aorta with the muscles. You can see the aorta is white. So this is a CCT image that is done. Can I tell me which organ is damaged? Is it the liver injury or spleen injury? What is damaged here? Is it the liver or spleen? What is damaged in this patient? You're seeing collection around the liver. You're seeing collection around the spleen. I'm asking you what is damaged. Please look at here. There is contrast extravasation occurring from the spleen. The blue arrow is pointing towards the contrast leak or contrast blush from the spleen. Contrast blush from spleen. So this is splenic injury. This is splenic injury. Remember, to know the organ of injury, right? What we do? CECT. To know the organ of injury, CECT is the investigation of choice to know organ of injury. So whichever organ is leaking the contrast, that is the organ that is damaged. So this is splenic injury. Splenic injury. I hope you can manage this. The investigation of choice to know the organ injured in abdominal trauma is contrast enhanced CT scan. Wherever contrast blush is occurring, that is the organ that is injured. So that is the reason non-contrast CT is not useful to tell which organ is damaged. You need to do CCT and see where the contrast is leaking from. This is contrast blush from the spleen. This is splenic injury. Important. This image here is showing contrast extravasation from the liver. This is how you have hepatic injury. This is hepatic injury that you have, right? So that is how we have hepatic injury in a trauma patient. These are easy for you. I hope you can see this biconvex, lentiform, does not cross sutures. This is right epidural hematoma. This is also right epidural hematoma or extradural hematoma. But what do you see here is this black areas, these hypodensities. This is called a swirl sign. It's swirl sign. What is a swirl sign? What does it indicate? It indicates active bleeding. Active bleeding. So one is right epidural hematoma, one is a right epidural hematoma with swirl sign. So early craniotomy or preferential craniotomy. So this is what is swirl sign. So these patients showing swirl sign, this indicates active bleeding. So early craniotomy should be done for these patients. So treatment of epidural hematoma is a craniotomy, right? So the early craniotomy or preferential craniotomy should be done in patients who are showing active bleeding, the swirl sign. This is eccentric, right? Concavo convex. This is acute because it is hyperdense, it is acute right subdural hematoma. This is crossing sutures, right, not crossing the midline. It is hypodense. This is chronic left subdural hematoma. So concentric crossing sutures, not crossing the midline, hypodense. Because it is hypodense, I am calling it chronic. Okay, so this is how we have chronic left subdural hematoma. And what do you have here? Hyperdensities in sylvian fissure, basal cisterns, interhemispheric areas, sulcal spaces. So when you see hyperdensities all like this around the sulcal areas, right, CSF cisterns, this is acute subarachnoid hemorrhage, acute subarachnoid hemorrhage. And if you see here, there is hyperdensity in the oxyl horn of lateral ventricle. This is intraventricular bleed, intraventricular bleed. What about these black red arrowheads that are pointing here? What do you think this is? This is subarachnoid hemorrhage, hyperdensities in sulcal spaces. These hyperdensities in sulcal spaces. So this is having both subarachnoid hemorrhage also, intraventricular bleed also. So the intraventricular bleed is seen in the oxyl horn of lateral ventricle. The subarachnoid hemorrhage is seen with the hyperdensities in the sulcal spaces. That is, both are there. Subarachnoid hemorrhage is also there and intraventricular bleed is also there. This is Mount Fuji sign. Mount Fuji. Air will come on the top. This is Mount Fuji sign. Air will come on the top. This is suggestive of tension pneumocephalus. Tension pneumocephalus. Mount Fuji sign. Right. This is hypertensive bleed, vitaminal bleed, hemorrhagic stroke. Remember, hemorrhagic stroke will be hyperdense, will be white. Whereas ischemic stroke or infarctions, they are hypodense. So on a non-contrast CT, you can easily differentiate a hemorrhagic stroke from a ischemic stroke. So hemorrhagic stroke will be hyperdense on CT and ischemic stroke will be hypodense on CT. And you are seeing here wedge-shaped area, gray-white matter interface in a right MCA territory. Right, so this is right MCA infarction, right MCA infarction showing this ischemic stroke or infarct. So the non-contrast CT is the investigation of choice for stroke patients. Investigation of choice for stroke. To differentiate hemorrhagic stroke from ischemic stroke, we go for non-contrast CT. If it is hyperdense, it is hemorrhagic stroke. If it is hypodense, it is ischemic stroke or acute infarct. Sometimes in a patient of hemiplegia, in a patient of cerebrovascular accident or hemiplegia, the CT scan can be completely normal. But when you do a diffusion weighted MRI, you get a classic light bulb appearance on diffusion weighted imaging. This is also suggestive of acute infarct. So the most sensitive investigation for acute infarct is diffusion weighted MRI. Most sensitive for acute infarct is diffusion weighted MRI. CT scan may sometimes be normal in case of acute infarcts. So which territory is involved here? This is left MCA territory, showing a light bulb appearance. So this is a case of left MCA infarction seen on diffusion weighted imaging. Remember, diffusion weighted MRI is for acute infarctions, acute infarct. And one of the important CT scan findings of acute infarct is this dense middle cerebral artery. This is called as a hyperdense MCA sign, hyperdense MCA sign, middle cerebral artery sign. So the middle cerebral artery that you have, this becomes very hyperdense. There is thrombus inside, so there will be a hyperdense area. So middle cerebral artery, because of the thrombus, will be a hyperdense area. But the brain parenchyma that you have, this will become hypodense. So don't get confused. Both of them are seen in acute infarct. Infarction will be hypodense on CT. Infarct area will be hypodense on CT. Hyperdense MCA sign, the vessel which is thrombused, will appear hyperdense. So hyperdense MCA sign is also a sign of acute infarct. How does infarct appear on CT? Hypodense. Infarct area appears hypodense. Hyperdense MCA sign is also a sign of acute infarct. So don't get confused with this thing that we have learnt. Hyperdense and hypodense. This is different. This is talking about the brain parenchyma. If you see a hyperdense area in the brain parenchyma, it is hemorrhagic stroke. If you see hypodense area in the brain parenchyma, it is ischemic stroke or acute infarct. But if the vessel shows hyperdense, that means it is thrombus, density is increased, there is a thrombus inside. So hyperdense MCA sign is also a sign of a ischemic stroke or acute infarct. Okay, so this is also a hyperdense MCA sign of acute infarct. This is white cerebellum sign. So you can see the cerebellar hemispheres, there are white, but most of the other brain parenchyma is hypodense. The most of the brain parenchyma is hypodense, but the cerebellum is white. This is called white cerebellum sign. Anybody, where do you see this white cerebellum sign? The cerebellum appears white and the rest of the brain parenchyma appears hypodense. Where do you see this white cerebellum sign? White cerebellum sign. Anybody? White cerebellum sign is seen. You can see the cerebellum appearing white compared to the rest of the brain parenchyma. This is seen in irreversible brain hypoxia. Irreversible brain hypoxia. Okay, irreversible brain hypoxia. This will have white cerebellum sign. The cerebellum has rich collateral blood supply. The cerebellar hemispheres will have rich collateral blood supply. There are so many blood vessels supplying it. ICA, PICA, superior cerebellar artery, right? So they all supply. And whenever there is hypoxia, the cerebellar hemispheres escape the salt, but rest of the brain parenchyma becomes hypodense. So it indicates a irreversible brain hypoxia. Any cause of hypoperfusion to the brain can produce this white cerebellum sign. This indicates irreversible brain hypoxia. It is a poor prognostic finding. It indicates poor prognosis. Okay, white cerebellum sign. Okay, before we go to the questions, we'll do some important, images. Okay, just a couple of images and then we'll go to the questions now. 10 o'clock, I think we should be able to complete and you'll have a comprehensive understanding of all the images that we have done. This is a normal scrotal ultrasound. Normal scrotal ultrasound. You can see this is the scrotal skin. This is the testis that you have, right testis and left, the normal scrotal ultrasound. And this is how the normal color fill will be there in the testis, right, in the testicular vessels. But look here, this is a patient with acute scrotal pain and you can see this right testis is showing good color fill, but there is no color fill in the left testis. This is how we have testicular torsion. It shows absent blood flow, right? The left testicular torsion that you have. But this patient is also acute scrotal pain compared to the right side and the left side. You can see the right side has lot of rich blood supply compared to the left side. So when you have increased blood flow, this is epididymoarchitis. This is right epididymoarchitis. So if you have a lack of flow, think of torsion. If you see increased flow, think of epididymoarchitis. So you should look at the ultrasound images, and that is the reason important to differentiate testicular torsion and epididymoarchitis. We go for color Doppler ultrasound. A color Doppler ultrasound can easily differentiate the patient who is presenting with acute scrotal pain. Is he having epididymoarchitis or torsion of testicular torsion? A torsion will show lack of blood flow, whereas epididymoarchitis, obviously there will be vasodilation, will be having more blood flow in that area. Okay. Let's do the questions. Are you all ready for the questions then? Shall we get started with the questions now? We'll answer more questions. Just tell me if you are comfortable with the questions. Can we get started? Okay, let's see how many questions we'll answer. Let's look at the next one here. 51. Okay. A 35-year-old female, known case of HIV with CD4 count less than 300, presents with fever, dyspnea, cough. X-ray has been taken. What is the likely causative organism? What do you see on the X-ray? Bilateral lung fields showing, right, millet seed-like opacities, the miliary mottling. This is HIV patient, immunocompromised patient. This is miliary TB, bilateral, right, bilateral lung fields. They show this millet seed-like opacities. This is miliary TB. What is a gold standard investigation for FES, functional endoscopic sinus surgery? So to look at paranasal sinuses, investigation of choice for paranasal sinuses is what? CT scan. So you have to get a CT scan before you get a functional endoscopic sinus surgeries. Okay. What is this? Try to answer this one, guys. 53. Try to answer 53. Let me see how many of you will get this right. Which of the following investigations can be used in osteoporosis? For osteoporosis, what are the investigations that we do? DEXA scan, quantitative CT, bone scan, serum chemical analysis. A, B, C, D. What are the investigations that are used in osteoporosis? DEXA scan, yes, we do DEXA, right? So a T-score that we do on DEXA, a T-score less than minus 2.5 standard deviation is called osteoporosis. Actually, quantitative CT is more sensitive to look at bone mineral density, especially for medullary changes, to look at the medullary bone. On a CT scan, if you want to look at the vertebra, changes in the medulla, not the cortical bone, to changes in the medullary bone, this deeper medullary bone, they are seen better on CT scan. So actually quantitative CT is more sensitive to look at bone mineral density changes than DEXA scan, okay? And chemical analysis like serum calcium levels, parathormone levels, we measure these things. But there is no role of bone scan. Bone scan only looks at osteoblastic activities. I told you, bone scan only checks what? Osteoblastic areas. It is not useful for osteoporosis. So the answer should be 1, 2 and 4. 1, 2 and 4. Okay, we don't do bone scan in osteoporosis, right? So 1, 2 and 4. Is this clear all of you? Bone scan सिर्फ osteoblastic areas देखता है. Bone scan is for osteoblastic activity. Osteoblastic activities. We don't use it in multiple myeloma. We don't use it in osteoporosis. Next one. Let's come to the next one. 54. A patient presented with pain in right upper quadrant on the 5th postoperative day following lap cholecystectomy. She is icteric and ultrasound. There is collection. A bile leak is suspected. What is the most sensitive investigation for bile leak? What is the most sensitive investigation for bile leak? Remember, the most sensitive investigation for bile leak is HIDA scan. HIDA scan. Most sensitive for bile leak is HIDA. But if they ask you gold standard or most important investigation to detect anatomical site of bile leak, anatomical site of bile leak. For this, what is the answer? To look at anatomical. HIDA is nuclear scan. They will not tell you the anatomical site of leak. HIDA scan will not tell you the anatomical site. HIDA will be like this. Around the liver, you see a collection, but I cannot see where is it coming from. Is it coming from right hepatic duct, left hepatic duct, cystic duct? I cannot tell where this is coming from. They are nuclear scans. Nuclear scans are functional scans. They don't give anatomical detail. They don't give you anatomical detail. So HIDA will not tell you anatomical site. What is the investigation to know the anatomical site of bile leak? ये कहाँ से आ रहा है? Right hepatic duct से आ रहा है, left hepatic duct से leak हो रहा है, cystic duct से leak हो रहा है. For this, we go for ERCP. Remember, anatomical site of bile leak is by ERCP. Right? You can do both diagnosis and stenting also. Diagnostic and therapeutic. ERCP is the gold standard to detect anatomical site of bile leak. ये दो याद रखो. Important clinical scenario. Lap cholecystectomy patient coming with pain and ultrasound showing collection. How do you know it is a bile that is collected there? HIDA scan is done. If HIDA is positive, if HIDA scan tells you there is bile leak, to know the anatomical site of leak, we go for ERCP. It is both diagnostic and therapeutic. Okay, let's look at the next question. A young male with head trauma is brought to emergency in unconscious state. He is intubated and low Glasgow coma scale, no verbal response or no movement on pressure, has features of increased ICT. NCCT, brain and spinal cord is normal. What is the likely diagnosis? So CT scan is normal, but poor Glasgow coma scale, unconscious patient, right? Unconscious patient. Please think of diffuse axonal injury. Remember, diffuse axonal injury, the investigation of choice is MRI. CT may be normal or shows petechial hemorrhages. Small petechial hemorrhages may be seen, but usually it is normal or shows petechial hemorrhages. The investigation of choice is MRI, right, for diffuse axonal injury. Next thing. 56, again a trauma patient, tachypneic, BP is slightly less, difficulty speaking, hyperresonant sound on percussion, right, and FAST is performed. FAST is normal. Remember, FAST will look at only hemoperitoneum and pericardial collections. It is EFAST that will check at, EFAST looks at pneumothorax because of the thoracic views, pneumothorax. with pericardial collection and hemoperitoneum. So it is saying fast is normal. EFA, not EFAST. It's only saying fast is normal. And X-ray, I hope you can see absent bronchovascular marking, visceral pleural line, collapse towards the hilum. This is pneumothorax. And pneumothorax, what do? You go for a wide bore needle followed by ICD. So wide bore needle in the fifth intercostal space followed by ICD. This should be the treatment. Okay. 57. A male patient, 40-year-old male, progressive forward bending, increased stiffness of the spine. A CT scan is given. You can see calcification of the anterior longitudinal ligament, and also you are seeing the fractures there. Okay, the carrot stick fractures that you are seeing. All of this indicates this is ankylosing spondylitis, right? There is forward bending, there is stiffness of the spine, the bamboo spine, right? Ankylosing spondylitis. What is the investigation of choice for ankylosing spondylitis? Stir MRI. What is the earliest manifestation that you see, earliest finding that you see in ankylosing spondylitis? Bilateral sacroiliitis, right? Bilateral sacroiliitis. This is ankylosing spondylitis. I hope you remember the radiological signs, the bamboo spine, the dagger sign, okay, the tram track sign, Romanas lesion. All of these are findings with ankylosing spondylitis. Let's look at the next one. Try to answer this one, guys. 58. Let's see if you can answer 58. Yes, Schubert test, right? There is a restricted lumbar flexion. There is an anterior bending of the spine, right? Very good. Schubert test is positive. 51. 51-year-old man presents with a history of smoking, pain in the right arm and ptosis, chest X-ray is given. So whenever you're given X-rays in the exam, don't look at heart, don't look at right lung, don't look at left lung and make diagnosis. Always try to look at the zones of the chest X-ray. So when you are given a chest X-ray, आप compare करो bilaterally symmetrically. Compare करोगे तो easily you can identify the pathology. So if you bilaterally symmetrically, you look at different zones, apical zone, middle zones, lower zones, like that. Okay, bilaterally symmetrically, if you can appreciate, you will be able to see this pathology here in the right apical region. This is compressing the sympathetic trunk, producing ptosis. It is compressing the subclavian vessels, producing pain in the right upper arm. All of this is Pancoast tumor, apical lung cancer, right? So apical lung cancer. Can I ask you what is the investigation of choice for Pancoast tumor? What is the investigation of choice for Pancoast? This is MRI. Okay, to look at the brachial plexus, the sympathetic trunk and the subclavian vessel invasion, MRI is the investigation of choice for Pancoast tumor. Good. MRI. Okay, so MRI is the investigation of choice for Pancoast tumor. Okay, look at this 59. A CT scan of the 50-year-old patient is given who presented with right upper abdominal pain. Which of the following statement is correct in this patient? Surgery is mandatory, etiology is echinococcus, angioembolization is indicated, FNAC is diagnostic. What do you see here? Here you are seeing this floating membrane or the water lily sign. This is echinococcus or hydatid, right? Echinococcus hydatid. Surgery is not mandatory. We give albendazole in the patient and see. And remember, FNAC should not be done because of hypersensitivity, right? Angioembolizations and all, we go for cancers, right? Not for this. So etiology is echinococcus. Next. Look at this next one. A 15-year-old female presents with shortening of limb, multiple swellings in the limb and multiple skin lesions. So there is a female patient, a 15-year-old female. Shortening of limbs are there, multiple swellings in the limbs. There are multiple skin lesions also. And X-ray pelvis is given. What is the likely diagnosis? There is an X-ray of the pelvis given. This is showing a shepherd crook deformity. Right? So like a shepherd crook, it is deformed. Deformity of the femur. So shepherd crook deformity of the femur. This is fibrous dysplasia. Fibrous dysplasia. Remember this shepherd crook, fibrous dysplasia, right? So this is fibrous dysplasia. And what is the clinical scenario showing? You're having a precocious puberty in a female. Precocious puberty in female. You're having ground glass areas in the bone. Fibrous dysplasia will have ground glass areas, ground glass opacities in the bone. Multiple skin lesions, that is cafe au lait spots. Cafe au lait spots, having the irregular coffee colored spots post of many appearance. Irregular coffee colored spots will be there. And you're having polyostotic fibrous dysplasia. All of this is McCune-Albright syndrome. McCune-Albright, right? All of this is McCune-Albright syndrome. Next, a radiograph of a patient for knee pain has been taken for the knee pain for the past 3 months is given. There is no history of trauma. What is the correct statement regarding the diagnosis and management? So you can see here, there is a triangular fragment of patella that is seen here on the superolateral aspect, right? There is a triangular fragment of the patella. So this triangular fragment of the patella, especially on the superolateral aspect of the patella, this is what is bipartite patella. It is not a fracture because no history of trauma is clearly mentioned. You're not thinking in lines of fractures, you're thinking of an anatomical variant that you have that is called as bipartite patella. So usually these are bilateral, so you can go for a radiograph of the other knee to identify whether there is a fracture or is it actually a bipartite patella. So bipartite patella is involving the superolateral aspect. The location will help you identify it more easily. The superolateral aspect of the patella, you see this anatomical variant that is called as bipartite patella. Next, look at this question, 62. Try to answer this one, guys. 62. Try to answer this one. A 60-year-old alcoholic male with a history of trauma 3 weeks back presents with confusion and disorientation. He is on treatment for alcohol dependence and his CT scan is given. What is the likely diagnosis? Intraparenchymal bleed, SAH, EDH or SDH? Now, here this is important to understand. Look at the image carefully, guys. Okay, ये NEET PG का question था इस बार का, so you have to understand this question carefully. First, understand the bones. This is the frontal, right? This is the parietal areas. So you're having this sutures here. And this bleed is crossing the sutures. You can see it is crossing the sutures. Don't worry much about the shape. Right? Don't worry much about whether it is biconvex or lentiform. More important is whether it is crossing the bones, crossing the sutures or not. So if you see it is crossing the sutures, this, which bleed crosses sutures? Which one do you think crosses sutures? It is the subdural hematoma. Subdural hematoma is crossing sutures. Epidural hematoma would not cross sutures. So you should see whether the hematoma is crossing the sutures or not. So here it is crossing the sutures. So this is subdural hematoma. Okay, ये पूछा गया था एग्जाम में, याद रखना. So more than shape, look for the sutures being crossed or not crossed. If you see the bleed is crossing the sutures, when you are not sure about the shape, look whether it is crossing the sutures or not. Then decide whether it is epidural or subdural. Okay. Look at this 63. A 35-year-old female delivered a baby at 32 weeks of gestation. The child has hepatosplenomegaly and jaundice. CT shows periventricular calcification. Obviously, periventricular calcification is feature of CMV, right? So this is CMV. Very good. Right? Next thing. Then look at this next one. A 25-year-old male with dull aching pain in the right loin for the past few months. Urine examination reveals sterile pyuria. What is the diagnosis based on the given radiograph? And on the given radiograph, you can see a very shrunken and a calcific kidney. This is a putty kidney, right? Putty kidney. And sterile pyuria is given, telling you it is renal tuberculosis. So renal tuberculosis, you will have this putty kidney and a cement kidney. Important. Okay. Look at this. Here, this is a 22-year-old female who is having a swelling in the forearm. What is the diagnosis based on the X-rays? What do you think is this? Here, this is more than 20 years, means mature skeleton. Mature skeleton. Mature skeleton means they'll be having fused growth plate. So all these mean the same only, fused growth plate. So more than 20 years, mature skeleton, fused growth plate, and there is a lesion in the epiphysis. Epiphyseal lesions, epiphyseal, subarticular, just under the joint. This is how you have GCT. But if it is same thing, epiphysis only, but less than 20 years is given in the question and immature skeleton is given, or you see unfused growth plate. Unfused growth plate. So if you see a lesion like this, the growth plates are unfused. And you're seeing the lesion like this, right? So you're seeing unfused growth plate, and also you're seeing a lesion in the epiphysis. So epiphysis less than 20 years, immature skeleton, unfused growth plate. What do you think it is? What do you think it would be? What do you think it would be? If it is a tumor in the epiphysis and less than 20 years, what is this answer? GCT always occurs in mature skeleton. GCT will always occur in mature skeleton, will always be above 20 years. बट अगर 20 ईयर से कम रहता है एज ग्रुप, अगर मैं इसी को 15-year-old गर्ल बोलता या 10-year-old गर्ल बोलता, तो क्या आंसर होगा? अनरिजबल बोन सिस्ट एपिफाइसिस से नहीं आएगा. अनरिजबल बोन सिस्ट कम्स फ्रॉम मेटाफाइसिस. आप लोग एपिफाइसिस का लीजन्स पढ़ते हो ना, ईसीजी बोल के, याद है? एपिफाइसिस में 2 ट्यूमर्स आते हैं, कॉन्ड्रोब्लास्टोमा, जीसीटी. तो अगर एपिफाइसिस दिया गया और लेस देन 20 इयर्स दिया गया, द आंसर शुड बी कॉन्ड्रोब्लास्टोमा. कॉन्ड्रोब्लास्टोमा. ABC, yes, agreed. It is also seen in immature skeleton, right? This will be in metaphysis. Metaphysis. Are we clear? It will also be less than 20 years, usually second decade, but metaphysis, not the epiphysis. Epiphysis bola gaya, so the answer should be chondroblastoma. Chondroblastoma. Are we clear? So this is, remember, ECG, the tumors in the epiphysis, chondroblastoma and giant cell tumor, also called as osteoclastoma. Osteoclastoma. Okay. Next thing. Look at the next one. A young male with low backache, morning stiffness, reduced chest expansion, redness of the eyes, there is uveitis, there is what is the diagnosis based on the history and the radiograph. And the radiograph is showing you this calcification of the periphery of the intervertebral disc and also the interspinous ligament. So you are seeing a dagger sign and a bamboo spine. So dagger sign and bamboo spine. This is ankylosing spondylitis. Okay, you're having the classic inflammatory arthritis that you have, right? So this is ankylosing spondylitis. Next. A 50-year-old female undergoes radiotherapy for CS cervix. Which of the following statement is true regarding ionizing radiation? So what is true regarding ionizing radiation? Normal cells and cancer cells are radiosensitive? Wrong. Which cells are more radiosensitive? Cancer cells, the highly mitotically active cells, they are more radiosensitive. More radiosensitive. Law of Bergoni. Undifferentiated cells, cells of high mitotic activity, they will be radiosensitive. GI mucosa is not radioresistant, it is radiosensitive. GI mucosa is a sensitive tissue. Remember, mucositis is a common complication that occurs after chemotherapy and radiotherapy, right? So GI mucosa is radiosensitive. Radiation at a point is inversely proportional to square of distance. This is inverse square law. Inverse square law. So this is correct. Inverse square law states that inverse square law states that the intensity of radiation is inversely proportional to square of distance. So this is a correct statement. Inverse square law. The intensity of radiation is inversely proportional to square of distance. So this is a correct statement that you have. Endothelial lining of blood vessels is resistant. The endothelial lining is sensitive. That is the reason in AV malformations, right, vascular malformations, we give radiotherapy. The endothelial lining is radiosensitive, not the, so we had to identify, not radioresistant. So we had to identify which is true. So C is the correct answer here. Look at 68. A 35-year-old patient presents with non-axial proptosis of the right eye. He has history of RTA 2 years back. The imaging is given. A homogeneous lesion is seen in the frontal sinus. What is the likely diagnosis? So you are seeing a proptosis with homogeneous lesion in the frontal sinus. This must be frontal mucocele. Okay, so trauma patient, old history of trauma, a homogeneous collection in the frontal sinus causing the proptosis. This is frontal mucocele. Okay. Look at this. A patient underwent NCCT abdomen, which shows a lesion in the liver as shown below. What is the likely diagnosis? So look at here. This is plain CT. The contrast is not there in the aorta. So this is plain CT, and on this plain CT, you are seeing a calcification of the cyst wall. Where do you see a cyst wall calcification? Cyst wall calcification. This is feature of hydatid. Cyst wall calcification. This is hydatid. Okay, cyst wall calcification is hydatid. Next. Look at this question. Elderly female, abdominal pain and distension. There is some deformity of the spine from childhood, progressive since then. Abdominal radiograph is shown. What is the likely diagnosis? Cecal volvulus, large bowel obstruction due to fecalith, large bowel obstruction due to sigmoid volvulus, small bowel obstruction. So because an elderly patient and you are seeing there is a cleft which is directed towards the left iliac fossa, you are seeing two loops, right? And you're not seeing any hastrations. All of this go in favor of sigmoid volvulus. Elderly patient, two loops are seen, no hastration, right? You are seeing three hyperdense lines, Riemann-Dahl sign that you say, okay, that all the three lines are there. This is sigmoid volvulus. Next, a child with respiratory distress and cyanosis. You are having a single S2 heart sound, ejection murmur telling you stenosis in the pulmonary area. Chest X-ray is given. You are seeing a concave pulmonary area, upward cardiac apex. This is boot-shaped heart. Boot-shaped heart, also called as cor and sabot. This is tetralogy of Fallot. Tetralogy of Fallot. Look at this one. A 25-year-old female with severe headache is advised CT scan of the head. Which of the following history you will definitely ask before CT scan? Look at the age group. This is 25-year-old. This is a 25-year-old female, so reproductive age group female. So you will always ask for last menstrual period. This is called 28-day rule. So whenever you are giving ionizing radiation, to a female of reproductive age group, you should always ask for last menstrual period to avoid damage to any undiagnosed pregnancy. This is called as 28-day rule. 28-day rule. Now, look at the next one. A 54-year-old male, painless hematuria, CCT is done, a mass in the right kidney is seen. What is the likely diagnosis? Is it angiomyolipoma, RCC, simple cyst, or is oncocytoma? Very good, painless hematuria, right? Heterogeneous enhancement. This is RCC, shows heterogeneous enhancement. Remember, angiomyolipoma, आप subcutaneous fat से compare करो. Look at this subcutaneous fat. It is less darker. If it is similar to subcutaneous fat, that would be angiomyolipoma, right? It is not similar to subcutaneous fat, right? You can see the mesenteric fat, you can see the subcutaneous fat. The fat density is different and the lesion is different. So this is not fat, this is RCC. If it was fat containing, it will be similar to subcutaneous fat. That would be angiomyolipoma. So जो black area दिख रहा है, compare it with subcutaneous fat. If it is appearing similar in nature, similar blackness is there, that is usually fat containing lesion, angiomyolipoma. But if it is not similar, think of a heterogeneous enhancement. Especially here, elderly patient, smoker will be given, painless hematuria is given. Go for, RCC as a better answer. Next, whole body CT will include all except. Remember, when we say whole body CT, we get a non-contrast CT of the head. Remember, head trauma, we go for non-contrast CT. We go for non-contrast CT of cervical spine. Then we inject contrast and we do CCT of the thorax to look at any aortic transaction, right? Any tearing of the aorta, any tearing of the superior vena cava, so any of these mediastinal vessels. You need to give contrast. You go for CCT. And also we go for CCT of the abdomen. You need to go for CCT of the abdomen to look at the organ injured. I told you, splenic injury, liver injury, we go for CCT. So head trauma, go for non-contrast CT. Abdominal trauma, go for CCT. So this whole body CT means we do all of this. Non-contrast CT of the head, non-contrast CT of the cervical spine, CCT of the thorax, CCT of the abdomen, but not the limbs, So except limbs, that is all whole body CT. Next, look at the next one. 75, a 34-year-old prima gravida is detected to have intrauterine fetal demise. IUD is there, so intrauterine fetal demise is there. And on ultrasound, there is hyperechoic air specks within the blood vessels. So air inside the great vessels and heart. Air within the great vessels, aorta, vena cava, right, and heart. This is called as Robert's sign. Spalding sign is overlapping of sutural bones. Overlapping of sutural bones is Spalding sign. Roberts sign is air within the great vessels and heart. Both of them suggestive of intrauterine death. Now look at this next image. This is a bone scan. Okay, a bone scan image is given. Bone scan is done with technetium 99M MDP, methylene diphosphonate. And this is a prostate cancer patient with elevated PSA levels, and he is showing increased uptake in the bones. You can see entirely diffusely increased uptake is there. But look at the kidneys. Are you able to see the kidneys? Are you able to see the kidneys? Can you tell me, are the kidneys visualized or not visualized? Are the kidneys visualized or not visualized? Not visualized. So if you have a super scan, it resembles normal bone scan. It resembles normal bone scan. It has same uptake in the axial skeleton, shoulders, sacral ala. So it resembles normal bone scan, but kidneys are not visualized. But kidneys are not visualized. This is called as a super scan. And पूछा जाता है super scan के causes क्या है? Please remember, super scan will be seen in renal failure. Yes or no? So obviously renal failure will show lack of kidney visualization. So renal failure में super scan आएगा. Super scan will be seen in diffuse osteoblastic metastasis. If you have lot of osteoblastic metastasis, prostate metastasis, right? Like prostate metastasis, you will see lot of MDP used in the periphery, nothing available for kidney. And even in case of hyperparathyroidism, you have lot of repair happening in the periphery. Lot of repair, subperiosteal erosions will be there. In hyperparathyroidism, you see subperiosteal erosions, right? And because of the erosions, there will be repair happening in the periphery. So MDP will be used up in the periphery. So you'll have this super scan even in case of hyperparathyroidism. So super scan due to diffusely increased uptake in skeletal metastasis. That should be the answer here. Okay, so prostate cancer patient showing a super scan. This is due to diffuse osteoblastic metastasis. Now, these are, they're asking you what is the Coinot segment of the liver. Remember, when you see the lung fields, you can see your lungs. When you see the lung fields, these are superior segments of the liver. When you see the kidneys, these are inferior segments of the liver. So you're seeing the lung fields, you're talking about the superior segments of the liver. And what are the superior segments of the liver? If you remember the Coinot segments of the liver is divided into right and left halves by middle hepatic vein. The right hepatic vein divides the right lobe into anterior and posterior parts. The left hepatic vein divides the left lobe into medial and lateral segments. Then you have the portal vein, which is in the same plane as your middle hepatic vein. And I told you portal vein goes transversely in the liver. Portal vein will go transversely in the liver, dividing the liver into 8 segments. So by labeling, remember caudate lobe is first lobe, posteriorly. Caudate lobe is the first, posteriorly. From the most lateral, right, start from second, third, fourth, fifth, right? This is fifth. Then second, third, fourth, fifth, sixth, seventh, and eighth. This again is empty, so we'll write it 4A, 4B. So just start from the most lateral, go in a clockwise direction, you'll get the segments of the liver. So what are the left lateral segments? 2 and 3. Left medial segments, right, 4A, 4B. Right anterior segments, 5 and 8. Right posterior segments, you will have 6 and 7. So left lobe is flat. So left lobe will have medial and lateral segments. Left lobe is flat, it will have medial and lateral segments. Right lobe is thick, so it will have anterior and posterior segments. So right lobe will have anterior and posterior segment, left lobe will have medial and lateral segments. So that is how we have the Coinot segments of the liver. And what are the superior segments we have? 7, 8, 4A and 2. So this one, the marked one here, right? This is 7, this is 8, right? Here you will have 4A, here we will have 2. So this would be segment 8, segment 8. So that is how we have the Coinot segments of the liver. Right? So this is superior segments that are asked. So go for the superior segments, superior segment 8. Okay. What is this radiograph showing you? What is this radiograph showing you? What is this radiograph showing you, guys? What is the diagnosis of based on the given image of a newborn? Very nice. This image where you have a metal button, you can see a metal button and you can see a rectal layer. This is invertogram. This is a invertogram. And this invertogram is done for evaluating anal atresia. Evaluating anal atresia. And this invertogram is usually done 24 hours after birth. You should don't do immediately, you should do 24 hours after birth. You want the gas to come in the rectum and look at the metal button. You compare this distance between rectal layer and metal button, right? So, is it a high anal atresia or low anal atresia? If this distance on invertogram, if this distance is more than 2 centimeter, the distance between the metal button and the rectal layer, the distance between the metal button and rectal layer, if it is more than 2 centimeters, this is high anal atresia. High anal atresia. And for high anal atresia, abdominal approach is preferred. Abdominal approach for surgery is preferred. But if it is less than 2 centimeters, this is called low anal atresia. For this, we generally go for a perineal approach. So, to know whether it is a high anal atresia or low anal atresia, we go for this invertogram. Remember, this is invertogram, where the child is inverted upside down direction. You measure the distance between the rectal layer and the metal button. So, this is done for imperforate anus. Imperforate. This is invertogram or anal atresia. It is not used to diagnose anal atresia. Anal atresia can be diagnosed clinically, right? When you see absence of the anal opening. It is done to evaluate anal atresia into high anal atresia or low anal atresia. And that is the reason it should be done 24 hours after birth. You wait for the gas to come in the rectum, right? You wait for the gas to come in the rectum. This is 24 hours after birth. Okay. What is this, guys? A newborn is having an abnormal lump on the lower back. Identify the condition based on the given MRI. You can see this is T1 weighted MRI. This is T2 weighted MRI. How do I know that? Look at the CSF around the spinal cord. If the CSF around the spinal cord is dark, it is T1. If it is white, it is T2. And you are seeing a swelling, right, which is not just having CSF, but also neural elements. You can see the spinal cord element also. So, what do you think is this? Very good. Many of you would got this right. Praveen, Divya, Aditi, Sai Kumar, Tanveer, right? Yogesh, very nice. Zainab, Sapna, very nice. Myelomeningocele, myelomeningocele. Now, myelomeningocele is 100% Chiari 2 malformation. Okay, so Chiari 2 malformation. Okay, so myelomeningocele is also in Chiari 2. Okay, look at this thing. What is the image? What is the type of fracture depicted on this image? So here you can see the orbital contents hanging into the maxillary sinus. So this is blowout fracture or teardrop fracture, or fracture of orbital flow, right? Orbital flow. Okay, 81. Try to answer 81. What is this? This is a patient with backache and paraspinal tenderness. Deep tendon reflexes are exaggerated. What is the likely diagnosis? So imagine you are seeing this lesion here involving the vertebral body and the disc. This is what spine? Tuberculosis of spine. So remember, TB spine is always paradiscal. The most common tuberculosis of the spine is paradiscal. So it will involve the disc. Imagine this is the disc and the vertebra. It will involve the disc and the end plates of the vertebra. So the most common type of TB spine is paradiscal. So it will involve the disc and the adjacent end plates of the vertebra. So that is how you have the TB spine or the pot spine. And the investigation of choice for pot spine or TB spine or anything with spinal imaging is MRI. So anything to do with spinal imaging is MRI. Now imagine this is the vertebral body, this is the disc, and this is the vertebral body. If you have a lesion involving the vertebra alone, not the disc, this is vertebral metastasis, vertebral mets. So vertebral mets involve the vertebral body, they spare the disc, whereas TB spine is involving disc and end plates of the vertebra, it is paradiscal. So here it is involving the disc and the end plates of the vertebra. So pot spine is a better answer. Look at this question here. What is the name of this investigation? Is it IVP, RGU, MCU, or ureterogram? What do you think is this answer? Very good. You can see the catheter. Please remember to look at the catheter in the external urethral meatus. And what are you seeing? You are seeing this is the penile urethra. This curved area is the bulbar urethra. And look at the posterior urethra. This posterior urethra is not seen clearly, but the anterior urethra is seen better. The anterior urethra is seen better. So if you see a catheter or a syringe in the anterior external urethral meatus, if you see a catheter or a syringe in the external urethral meatus, and you are seeing the anterior urethra much better than the posterior urethra, the answer is RGU. So this is RGU. Remember, RGU is the investigation of choice for two important conditions. It is the investigation of choice for urethral strictures, which commonly occur at the bulbar urethra. So you have a STD patient or a patient who has a previous history of faulty catheterization coming with a narrow stream of urine, you are suspecting urethral stricture, get RGU done for it. RGU is also the investigation of choice for urethral trauma. So when you have blood at external urethral meatus, in a cyclist with straddle injury, right, you are having a blood external urethral meatus, right, you get a RGU done to look at urethral injury, right. So RGU for urethral trauma and for urethral strictures, we go for RGU. If you see the bladder and you see the posterior urethra better, so remember RGU is for anterior urethra, RGU is for anterior urethra. But if you see the bladder, that is micturating cystourethropy, you see the bladder and the posterior urethra. So this is mainly for posterior urethra, right? And the patient will be actually urinating. You will not see catheter at the external urethral meatus. You will see the patient actually voiding or urinating there. And that is micturition cystourethropy. That is mainly seeing the posterior urethra. Micturition cystourethropy is an investigation of choice for posterior urethral valve. So a young boy with narrow stream of urine, a young child, male child with narrow stream of urine, you are suspecting posterior urethral valve. Posterior urethra, go for MCU. Anterior urethra, go for RGU. And also it is an investigation of choice for vesicoureteric reflux. Look at the reflux. The bladder should be contracting. Only when you have a contracting bladder, then only reflux will occur in the ureter. So a static imaging will not show you reflux. Reflux will be when a bladder is contracting or actively voiding. So the investigation of choice for vesicoureteric reflux as well as for posturethral wall is what? MCU. Now identify the given X-ray, right? What is this view that is you have? This view where you see the petrous ridge, this is the petrous ridge that you have. It is below the maxillary antrum. These are the maxillary antrum and the petrous ridge is below the maxillary antrum. This is Waters view, right? This is Waters view. Towns view is AP view of skull with 30-degree angulation. And Towns view is mainly done for foramen magnum. Okay. Waters view is occipitomental. So this is the mentum, occipitomental view with closed mouth. Culval view is occipitofrontal, right? So Culval Waters view is for maxillary sinus, we all know this, and this is for frontal sinus. Right? Remember this thing. And Perry view is there. This is occipitomental with open mouth. Right? So remember open P. Open mouth is Perry view, closed mouth is Waters view. Next, just now we learnt Sterling sign on barium study is a feature of. What is Sterling sign? I taught you whenever we have tuberculosis, right, there is terminal ileum involvement, ileocecal valve thickening, right, narrow terminal ileum. So the contrast will go into the normal areas but will be washed off fastly from the diseased areas. Rapid emptying of barium from the diseased areas. This is called a Sterling sign, feature of ileocecal TB. Okay, ileocecal TB. This is Sterling sign. And look at this question 85. Try to answer this 85 question. What do you think is this? Following CT scan image shows. I hope you can identify that there is a hyperdense middle cerebral artery. Okay, there is a hyperdense MCA sign. There is a hyperdense MCA, middle cerebral artery sign. But which side is this? Right side or left side? I hope you know the CT. This is always right. This is the left side. And what does this indicate? Acute infarction. Hyperdense MCA indicates acute infarct. This indicates acute infarct. So what should be the answer here? This should be left MCA infarction. Okay, there is a thrombus in the left MCA causing acute infarct in the left MCA. So this is left MCA thrombus, right? So answer is D. Answer is D. Good. Okay. Look at this question. A CT angiogram image of a child with high output cardiac failure, and what is the likely diagnosis? So it's a child with cardiac failure, congestion, and the CT scan image is given. So whenever you have a child with congestive heart failure and hydrocephalus, right, neurological defects, hydrocephalus, and you are seeing a vascular swelling, a midline vascular swelling. This is classic vein of Galen malformation, right? So you can get an intracranial bruising, right? So a vascular noise, intracranial bruising you can get. This is vein of Galen malformation. Please remember, vein of Galen malformation is a misnomer. This is a misnomer. It is neither vein of Galen, it is neither a malformation. What is dilated is a prominent median prosencephalic vein. Prosencephalic vein. And it is not a malformation. There is no nidus. So malformation will have a nidus. So there is no nidus. So there is not called malformation. This is AV fistula actually. AV fistula. So vein of Galen malformation is a misnomer. And malformation should have nidus, but there is no nidus here. So you better call it what? AV fistula. So it is AV fistula and this median prosencephalic vein that is dilated, not the vein of Galen. Okay. Next. Look at here. There is a 5-year-old child with visual defects, motor and cognitive, progressive motor and cognitive defects that you are having. And what do you see on the MR imaging? You will see there is bilateral occipital lobe involvement. If you are seeing bilateral occipital lobe involvement, this leukodystrophy that you are having, the white matter involvement, the cortex is okay. The white matter is involved in the bilateral occipital lobes. So this is adrenoleukodystrophy. Bilateral occipital lobe white matter is involved. Right, leukodystrophy involving bilateral occipital lobes. MLD, metachromatic leukodystrophy, has tigeroid appearance or leopard skin appearance or lamellated appearance, right, on MRI. Alexander's is bilateral frontal lobe involvement. Canavan's is diffuse, everything is involved. There is no particular lobe, diffuse involvement, and you have N-acetyl aspartate peak. Right, so these are the different metachromatic leukodystrophy involves deep white matter with lamellated or tigeroid appearance. Remember, MLD has leopard skin or tigeroid appearance or lamellated appearance. Okay, so leopard skin appearance, lamellated appearance, leopard or tiger skin is same. Tigeroid appearance on MRI is metachromatic leukodystrophy. Adrenoleukodystrophy is bilateral occipital lobe involvement. Alexander led from the front. Alexander the Great led from the front. Remember, Alexander's is frontal lobe involvement, right? Canavan's is having Na, right? Canavan's is N-acetyl aspartate peak is seen with Canavan's disease. Remember this leukodystrophies. Now try to answer this question, guys. 88. So the answer here should be adrenoleukodystrophy. We are seeing bilateral occipital lobe involvement. Answer should be adrenoleukodystrophy. Answer 88. A 25-year-old young male present with abdominal pain after sustaining blunt trauma to his abdomen during a road traffic accident. BP is 120/80, pulse is 72. What is the next best step in the management? So abdominal trauma, right? Blunt trauma abdomen. Patient is stable. So anytime you have blunt trauma abdomen, whether the patient is stable or unstable, you always start with E-fast or fast, that is ultrasound. So the answer should be ultrasound. Don't do this wrong. Don't do this question wrong again and again. It's a very important topic. Blunt trauma abdomen, patient stable or unstable, get fast or E-fast done, that is ultrasound done, sonography, right, for trauma. On E-fast, if they say it is positive or fast is positive or hemoperitoneum is there, if they mention something like that, that fast is positive or hemoperitoneum is there in the patient, right, then look for vitals. If the vitals are stable, then you go for CECT to know organ of injury. If the vitals are unstable, go for emergency laparotomy. So never, jump the protocol. Whether the patient is stable or unstable, always do ultrasound, fast or e-fast, to know whether there is hemoperitoneum or not. Don't directly do CECT. Okay, first we want to get an ultrasound done. Okay. What about myocardial viability? Remember, thallium-201 is for myocardial perfusion. Myocardial perfusion. Sestamib is mainly used for parathyroid adenoma, localization of parathyroid adenomas. We can also use it for myocardial perfusion. Okay, perfusion also, myocardial perfusion. Pyrophosphate is for myocardial infarction. It shows infarcted area. Glucose will be taken up by living cells, not taken up by dead cells. So the viability is seen by 18-FDG. The viability, myocardial viability is by 18-FDG. The perfusion is given by thallium-201, whereas the infarction is given by pyrophosphate. So remember, infarction is by pyrophosphate and viability is by 18-FDG PET. 18-FDG PET is the answer. Now this is one-liner question, dependent Vistra sign. Anybody can answer dependent Vistra sign? Diaphragmatic rupture, fracture bronchus, pneumoperitoneum, diaphragmatic hernia. Diaphragmatic rupture produces dependent viscera. So when the dome of the diaphragm or a diaphragmatic rupture happens, the organs, the spleen, the stomach and all, they go posteriorly and lie onto the rib cage. So there will be a dependent viscera that you see when you have a rupture, fracture of, or damage to the diaphragm. Diaphragmatic rupture produces dependent viscera sign. Just one word answer, you learn dependent viscera. What did I taught you for fracture of bronchus? Fallen lung sign. Some signs in pneumoperitoneum, Dogi's cap sign, Dogi's cap sign. We talked about cupola sign, Wriggler's sign. We also talked about telltale triangle sign, right? So these are some signs of pneumoperitoneum. Next, 91. 57-year-old male presents with progressive atrophy of hands and forearms, spasticity of his lower limbs and hyperreflexia. T2-weighted MRI shows high signal in corticospinal tracts. So the MRI is showing corticospinal tract involvement. That is motor tract involvement. So it is a motor neuron disease that you have, spasticity and all of that. So this is amyotropic lateral sclerosis. There will be bilateral corticospinal tract involvement. Bilateral corticospinal tract involvement. And I taught you in your classes and in the video lectures also, doctor tutorials, okay, and even in the classes also we mentioned that bilateral corticospinal tract involvement gives this wine glass appearance on MRI. Wine glass appearance on MRI. Wine glass appearance on MRI. Bilateral corticospinal tract involvement. This is wine glass appearance on MRI. This is amyotropic lateral sclerosis. What causes this subacute combined degeneration of spinal cord? Did you hear this anytime? Subacute combined degeneration of spinal cord. Where do you see this? Subacute combined degeneration of spinal cord. The answer here should be amyotropic lateral sclerosis, okay, corticospinal tract involvement. But I'm asking, where do you see subacute combined degeneration of spinal cord? ये कहाँ पे होता है? Very good, B12 deficiency, right? So B12 deficiency, right? And Tabes dorsalis is neurosyphilis, right? Neurosyphilis. Argyll Robertson pupil. Tabes dorsalis, neurosyphilis. Fine. Okay. Slightly tough question. 92, can you try? The following chest radiograph of a patient with shortness of breath and fatigue suggests the diagnosis of. Look at the chest X-ray. What is it? Mitral stenosis, aortic regurgitation, atrial septal defect, or pericardial effusion? What do you think is this image showing you? First of all, look at the right heart border, look at the left heart border. Which side is enlarged? What do you think is enlarged? Right side or left side? आप लोग देख के बताओ, right side बढ़ के या left side बढ़ के? Right side बढ़ के या left side बढ़ के? What do you think is increased actually? Right heart border or left heart border? पहले इतना बताओ. Let us just do it one by one. Is it the right heart border increased or left heart border increased? The left heart is increased. Now, so this is left ventricular hypertrophy in the patient. Left ventricular hypertrophy. Mitral stenosis, will you have left ventricular hypertrophy? No. Right? It will be left atrial enlargement. Mitral stenosis will cause left atrial enlargement, not left ventricular hypertrophy. Aortic regurgitation, when you have blood coming back into the ventricle, obviously you may have left ventricular hypertrophy. And look at the aorta also, very prominent and visible, right? So this could be the correct answer, right? The chronic aortic regurgitation. Atrial septal defect, again the left ventricle will not be enlarged here. Pericardial effusion, you will have bilaterally the cardiac silhouette increased. In pericardial effusion, the money bag appearance, both sides will increase. The money bag or leather bottle appearance, both sides will increase. So this is actually a chronic aortic regurgitation, not a money bag appearance. Okay, so pericardial effusion, दोनों side increase होगा. Okay, look at 93. Can you tell me what is 93? A 60-year-old female with intermittent bleeding per vagina, endometrial collection with thickening and anterior bulging of fundal area. On ultrasound, a feeding vessel on Doppler. So there is a elderly female, postmenopausal female, bleeding per vagina is seen. There is endometrial collection and thickening and anterior bulging of the fundus. The ultrasound shows a classic feeding vessel sign on Doppler. So this is definitely endometrial polyp. So pedicle artery sign. Pedicle artery or feeding artery. So when you have endometrial polyp, this is also in case of postmenopausal female. This also produces endometrial thickening, but a focal thickening. The anterior bulge tells you it is a focal thickening. And through the stalk, you have a blood vessel entering into it. So that is called as pedicle artery or feeding artery sign. So pedicle artery or feeding artery sign is suggestive of endometrial polyp. Both of them, endometrial cancer, endometrial polyps, are common in postmenopausal female. Both of them can present with vaginal bleeding. So be careful with the question whether you say focal thickening or diffuse thickening. Endometrial cancer is diffuse thickening. This is diffuse thickening, right? Whereas endometrial polyp is focal. So here you are seeing anterior bulge, focal thickening, and you are seeing the feeding artery sign. 94. A female with multiple transient ischemic attacks, a young female, 35-year-old female with multiple transient ischemic attacks, given carotid angiogram, shows a beaded appearance of the carotid artery. So female, young female, right? And you are seeing either a beaded appearance or tortuous appearance or pile of plate appearance. Most commonly of the renal artery, producing hypertension in the patient. Second most common is your internal carotid artery, producing transient ischemic attacks. All of this is what? Fibromuscular dysplasia. So the most common artery, fibromuscular dysplasia. The most common artery involved in fibromuscular dysplasia. So either you have a beaded appearance or tortuous appearance or pile of plate appearance of renal artery or of the internal carotid artery. Both of them are fibromuscular dysplasia. 95. A child with abdominal pain and vomiting. A child abdominal radiograph is given. What is the likely diagnosis? What do you think is this? This is the stomach. This is the first part of the duodenum that you have. How many bubbles you are seeing? Double bubble. So double bubble would be duodenal atresia. So you don't see duodenal atresia here. What is the next best answer that I can choose here? Very good. Annular pancreas. I told you, right? LAD. Bands, annular pancreas, and duodenal atresia. They produce double bubble appearance on the abdominal radiograph. Okay, let's look at this 96. A 55-year-old male presents with sudden onset, shortness of breath, chest pain, and ST elevation. A chest radiograph is obtained. What is the probable diagnosis? So you can see here, sudden onset of breathlessness, ST elevation. You're thinking of, lines of MI. And your chest radiograph shows perihilar opacities in a Batwing configuration. This is acute pulmonary edema, Batwing configuration, Batwing opacities. This is acute pulmonary edema, right? Next. 97. 97. A 20-year-old male presents with severe headache, paralysis of upward gaze. CT scan shows a hyperdense lesion on the posterior aspect of third ventricle. A homogeneous intense contrast enhancement, most probable diagnosis. So a patient is having paralysis of upward gaze. There is a lesion on the posterior aspect of third ventricle. What is normally located posterior to third ventricle? The pineal gland is located just posterior to third ventricle. I hope you remember your classes that I taught you or in the video lectures that we discussed. In the third ventricle, posterior to third ventricle, we have pineal gland. Pineal gland. So whenever we have a pineal gland tumor, it will compress the superior colliculi, producing upward gaze palsy. So a pineal gland tumor generally is a germinoma. Most common lesion is a germinoma. And it compresses superior colliculi. and produces upward gaze palsy. Upward gaze palsy. Superior colliculi are responsible for upward gaze. So produces this upward gaze palsy. This is called Perinaud syndrome. Perinaud syndrome. Right? Perinaud syndrome. So here it should be germinoma. So look at the location, posterior to third ventricle, producing upward gaze palsy. The Perinaud syndrome is being described here. So that is because of the simple anatomy, okay, of where the pineal gland is located, just above the superior colliculi. So whenever you have a pineal gland tumor, the most common pineal gland tumor is a germinoma. It compresses the superior colliculi, producing upward gaze palsy. That is Perinaud syndrome. Okay, 98. 97 is germinoma. Okay, so it is describing Perinaud syndrome, and that is generally due to a pineal gland tumor. The most common pineal gland tumor is germinoma. Okay, the answer is C. 98. 98, let us see. A 45-year-old female with progressive shortness of breath and bilateral basal rails show a traction bronchiectasis. So when you have bibasal reticulations, you're having traction bronchiectasis, you're talking about interstitial lung disease. There is bibasal fibrosis, right? Interstitial lung disease, pulmonary fibrosis, loss of volume of lung on HRCT. And barium swallow shows a very dilated patulous esophagus. Okay, dilated esophagus is there. So the contractions of the esophagus are not happening. The muscle is getting fibrous. So you're having a dilated patulous esophagus. All of these go in favor of scleroderma, right? Interstitial lung disease, right? Pulmonary fibrosis, dilated esophagus. You may be given, right? Soft tissue calcinosis, right? Crest syndrome, Raynaud's phenomena. Any of that can be mentioned. So here it is showing pulmonary fibrosis and dilated esophagus. Think of scleroderma. Okay. What is this? A chest radiograph showing obtained from a newborn with tachypnea and cyanosis. What is the likely diagnosis? So you can see, what do you think is this 99, guys? Very good, congenital diaphragmatic hernia. Remember, congenital diaphragmatic hernia is commonly associated with left lung hypoplasia. Right? Pulmonary hypoplasia can be there because of the compression of the lung by the bowel loops, right? So pulmonary hypoplasia can be seen in these patients. 100, what is 100? A 15-year-old patient undergoes a paranasal sinus surgery. Post-op vitals are stable. Patient is breathing spontaneously but not opening eyes. A CT scan is done. What is the most likely diagnosis? This is a patient underwent paranasal sinus surgery, right? Breathing spontaneously, not opening eyes. So it's like after surgery is not opening the eyes and all. A CT scan is done. What is the most likely diagnosis? Very good. Mount Fuji sign, Mount Fuji sign, pneumocephalus. This is Mount Fuji sign. Just now we discussed, right? So Mount Fuji sign. This is pneumocephalus, pneumocephalus. Very nice. Let me see how many questions. I think 100 should be fine. 100, this 101 you do? 101? Can you just think about 101? What is this? A 10-year-old boy with high-grade fever and throat pain looks toxic. His BP is 100/70, pulse rate is 105, and the respiratory rate is 28 per minute. Examination of the throat shows erythematous swollen tonsils and uvula in the midline. The child completed his immunization schedule on time. A lateral cervical radiograph from the child is shown below. Most likely diagnosis is. Very nice. Zain Baditi Yogesh, right? So this is a retropharyngeal. This retropharyngeal. You can see this swollen soft tissue with air pockets there. This is retropharyngeal abscess. What do you want me to explain, Danish? Which one do you want me to explain? Mangesh, which one? This one. Mount Fuji sign, right? So there is air. I just taught you, right? Now remember, this is acute onset. This is not chronic onset for you, right? This is acute post-op surgery, right? So paranasal air sinus, right? The surgery is also of the air pockets, right? And the patient is showing this air pockets anterior to the frontal lobes. So this is Mount Fuji sign classically. Now, which one are you confusing? Remember, this is not any acute, right? It is acute will be hyperdense. Chronic subdural hematomas, this will be cricentric, and there should be old history, chronic history, and this will be hypodense, but it will be cricentric, not like it will not cross midline. Here it is crossing midline. So you cannot think of chronic subdural hematoma. Are we clear with that? So crescent rake does not cross midline, all of that. And this is very chronic, but here it is acute onset and it is, Mount Fuji, the classic radiological sign. Is it okay, Mangesh? Right? So I hope this, discussion helps you, and we'll try to see that you have regular interaction with all of us, and there are some really good lectures lined up for you all. So do take part in that, intensive, remarkable rapid revision that is being planned by Dr. Reals in association with ISM EduTech. And I hope, you get some important questions in the exam and helps you clear this exam. And, at this point of time, it is also going to be about your mental strength. Okay, you will going to get some low days. You are going to get some, hours that you're not very active or not very proactively studying, where you're feeling fatigued or exhausted. Don't, give up on that. It is all about fighting back. It is all about coming back on track. It is not about becoming low. You will have some low phases. It is all about fighting back and coming back on track. How good you are fighting back to be on track, and how good you do this 40 days nice good revision, that will decide. The major hard work is already done. Accumulating this knowledge, accumulating this subjects, that is a major work. That most of that hard work is already done, guys. Okay, itni dur aaye ho, don't leave it like this. Okay, so just always have a positive self talk with yourself, always have that hope that good things will happen, and keep going with a very positive spirit. It is all about fighting back to be on track. Okay, and you don't have to do anything extra. Just how you were studying in the next 40 days also, if you hold on to your nerves and do, very, very sincere efforts, right, good things will happen. Okay, and last year also we had at the same regular batch, when they were writing, we had 35% pass percentage, and that was, amazing percentage. And I'm sure many of you guys will have a good results. So given your 100%, 40 days magic will happen. Remember, when you are studying, right, when you are studying your original subjects, each week you were studying couple of subjects, 2-3 subjects per day, per week, right? So 2-3 subjects you were able to complete in a week's time, even when regular classes you are sitting and studying. So in 40 days, there is a lot of magic, something that you already studied, that you have done your test and discussions, that you have done with your, lecture notes. At this phase of time, it's going to be about your mental strength to fight back and stay on track. Okay, and I'm sure you will all be willing to give that 100%, and okay, ho jayega. Okay, just believe that, have a positive, do not get into a negative loop. Negativity बढ़ेगी, positivity बढ़ेगी. अगर आप नेगेटिव टॉक करते रहोगे, if you speak negative about it, it will become more, it keeps on increasing. If you are having a positive self talk that yes, मेरा इतना सब्जेक्ट हो गया, आज रेडियोलॉजी का रिवीजन हो गया, अच्छे से एक बार कर लिया, 100 क्वेश्चंस तक कर लिए भी साथ में, right? You have a positive self talk with you. Keep on doing this on an everyday basis. That positivity will help you overcome this phase. Okay, so stay blessed, and I hope you have a good exam. Stay connected with me on the Insta also, and for all detailed lectures, you can watch me in detail, the entire, the physics related to X-ray generation, CT scan, MRI. I have done a detailed discussion in Dr. Tuel's original video lectures. You can always look into that, and we'll be happy to help you in always. Okay, all the best. Thank you so much, guys. Take care.